Hello, 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 hello. Mic test, hello. Okay, see soon. Hello, 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 hello. Mic test, hello, 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 hello. Mic test, hello, mic test, hello, hello, mic test, hello, 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 hello. Mic test, hello, hello. Mic test, mic test. Okay. Sure. Connecting. Hello, hello, habibi. Hello, hello. السلام عليكم ورحمة الله وبركاته. كيف حالك يا حبيبنا؟ كل معنا كل في محله. كيف حالك؟ كويس. الو 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 الو. قبل
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. Welcome, second day conference. And the moderator will be Dr. Abdul Halim Al-Marashi. Welcome, Dr.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, ladies and gentlemen. We are starting the second day in the annual diabetes conference in Madinah that organized by Prince Mohammed bin Abdulaziz for National Guard Hospital in Madinah. In this day, we have 3 sessions in the morning. In addition, we have 2 workshops in the afternoon. The first talk today will be about diabetes and post-COVID-19 syndrome, that it will be presented by Dr. Samia Sabor. Dr. Samia Sabor, she is a consultant of family medicine. At the same time, she is the head of family medicine department in Prince Mohammed bin Abdulaziz for National Guard Hospital in Medina.
بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. First of all, I would like to thank the organizing committee for this conference and their continuous activities in the field of diabetes, which is a really major problem all over the world. Today, I'm going to talk about diabetes and post-COVID-19 syndrome. And we will discuss how these 2 things are related in a vice versa way. I guess everyone has a certain memories for that days, right? I hope that it was not a very painful memories. Did we ever see this view at any time in your life, except in the pandemic? This was never expected to be seen, in fact. Also, we never expect to see the crowded streets in Riyadh to be empty in this way or anywhere in the world. This is enough to talk about COVID and how was the effect of that pandemics. Statistics also talk about these pandemics and how was the effect of it. In fact, when we see these numbers, the millions and almost half billions of the number of cases and even the mortality, Alhamdulillah, our country was one of the very successful countries to overcome this pandemics, although we are still seeing some few numbers of the cases. But in general, the mortality was not that fearful, alhamdulillah, although the pandemic itself was really fearful. So the questions now, does COVID-19 really end? If it really ends, what about these symptoms, which we are still seeing with people who had COVID at a time? We are still seeing patients who had a history of COVID, while they have until now menstrual problems, hair loss, cognitive problems, loss of appetite, dizziness, fatigability, and many of symptoms. Abdominal pain, cough, depression, dizziness, fatigability, and anxiety, and a variety of symptoms. And to the extent that WHO defined what is called post-COVID-19 syndrome, that it occurs after the disease 3 months or less or more, and it lasts for at least 2 months and cannot be explained by another diagnosis. The symptom is very wide in range, and it could be up or down, it could be fluctuated, and it can happen from the initial days of the disease or after. And there is many types of the long COVID disease. Type 1, when there is symptoms with a varying length of recovery and rehabilitation that directly correlate with the severity of infection, target organ damage, and pre-existing medical condition at the time of initial infection. Type 2, when the symptoms persist for 6 weeks from the time of initial infection. Type 3 is when the period of almost recovery or near recovery following initial infection, followed by a return of symptoms that persist for more than 3 months or even more than 6 months. Type 4, when initially a patient become asymptomatic at a type of COVID positive, but develop symptoms beginning 1 to 3 months or even after 3 months and later persist for a varying length of time. Type 5, which is the surprise, is that initially the patient will be asymptomatic or minimally symptomatic, but he will have a sudden death after within the next 12 months. So these are various types of long COVID syndromes. In fact, such a disease, which we had this long suffer, of course, it deserves to be studied, and many papers were published for this long COVID syndrome. This is one of it, and it concludes that approximately 30 to 40% of people with severe COVID-19 related morbidity, including hospitalization or intensive care, and the mortality have diabetes. Among hospitalized individuals with diabetes and COVID-19, anywhere between 21 to 43 required ICU care, and the case fatality was high, 25%. Risk of severe morbidity and mortality is really very high, 100 to 250% higher among patients with COVID-19 with diabetes compared to those without, even after adjustment of socio-demographic or comorbid factors. So now we can see clearly that diabetic patients, whenever they got a COVID, they have a different stories. And we will see the other face of the stories as well. That's why, or this is because the potential mechanism accounting for the effect of COVID on glycemic regulation, it is through the SARS effect, or COVID virus directly attacks the beta cells and binding to the ACE receptors. This will activate the inflammatory process and releasing of interleukin 6 or CRP or neutrophils, affecting CD4, CD8, and T cells. All these overactivations of the inflammatory process will cause insufficiency of insulin synthesis and systemic insulin resistance. With the management of the disease altogether will lead to impaired glucose regulations and increase the susceptibility and severity and mortality. On the other hand, people who are already diabetic, they, of course, they have attenuation of their innate immune response, and this will increase the activity of ACE2 receptors and will exacerbate the problems. This was early announced in the or published in the Lancet Diabetes of Endocrinology, where they mentioned the burden of diabetes in COVID patients. Another paper which talk about the COVID-19 infection that increased the risk of developing diabetes, and it was stated that of the patient who did develop diabetes, more than 99% developed type 2, which is the most common form of diabetes. This is another paper which is talking about post-COVID syndrome with diabetes, and the conclusion that is the strict control of diabetes and other comorbidities with the supervised rehabilitation, physical exercise, and optimal nutrition can help in reducing and managing post-COVID syndrome. Another publications also was talking about the effect of COVID-19 on diabetes people who got COVID-19 have a greater risk of developing diabetes up to a year later, even after a mild COVID infections. And this is compared with those who had never, who never had the COVID disease. This is what's reported with another fact that people who had COVID-19 were about 40% more likely to develop diabetes up to a year later than the control group. And for every 1,000 people studied in each group, roughly 13 of them were more individuals in COVID group were diagnosed with diabetes. And almost all cases detected were type 2 diabetes in which the body becomes resistant because of the mechanism I explained already. So there is, in fact, many of the publications talk about the effect of COVID infections on diabetes and vice versa. The chance of developing diabetes rose with increasing severity of COVID-19. People who were hospitalized or admitted to intensive care had a roughly triple the risk compared with control individuals. And of the people with COVID-19 who avoided hospitalization, an extra 8 people out of 1,000 studied had developed diabetes a year later compared with people who were not infected. And people with a high BMI also had a negative effect and had a considerable risk factor for type 2 and had more than double the risk of developing diabetes after COVID infections. This is another paper were published early on after the pandemic, where they reported that there was no data showing an increased risk of contracting COVID infection in diabetic, but that proved to be the opposite. On the other hand, diabetic patients, they were reporting that they have to have a special attention in since diabetes is associated with more severe disease. Ministry of Health, they did a large scale studies through virtual calls for more than 2,000 cases in around 22 centers, where they collected data about the long COVID symptoms. And they analyzed it. They studied over 6 months through the 937 calls. And this was the result. They found that there is a number who had these were the major symptoms: depression, well-being score obviously affected, and dizziness scale as well, and anxiety. The chronic fatigability was the highest symptoms in this study. And they concluded that the required management plan, and generally the patients will need nothing, and majority of them will need just a reassurance. Otherwise, they could have a follow-up in the post-COVID clinics with health education, and they can continue their follow-up in the primary care centers. They concluded also that further investigation into post-COVID cases are required in the kingdom, and majority of them they need nothing, and many of things were linked to the need for referral, including the severity of COVID infections, the age group, genders, and other risk factors. The recommendations were summarized in that informing COVID patient about the potential long-term sequence has to be done, because patients will be kept surprising from this continuation of symptoms, and sometimes it is a very bizarre symptoms. Doctors also should be aware of the various causes of symptoms such as fatigue, cognitive and neurological symptoms, dyspnea, in order to avoid misinterpretations and better manage and assist those who are predisposed to persistent symptoms. Establishment of an outpatient clinic setting and for post-COVID patient for evaluation, monitoring, support, and management of recovered cases. Also, they recommend to develop a well-structured post-COVID management protocol and guidelines based on the national evidence, and to have an additional research in this field. For post-COVID infection, there is, in general, patient recovering from COVID may experience a range of impairment requiring multidisciplinary rehabilitation. Care protocol should include assessment for anticipated impairment for all patients admitted to ICU or older patient, and patient who had severe critical disease may require a period of inpatient rehabilitation as well. Educational resources and remote delivery should be utilized to help the support of such people. This is regarding management of diabetic patients who got the COVID and they are diabetic. Did they have to have a certain plan of management for their diabetes? This paper recommended the following, that consistently they advocate for the use of insulin for a critically ill patient with COVID-19, but they are less consistent in guidance for other glucose-lowering drug classes, and the maximum severity of COVID-19 where various publications have recommended that metformin, SGL2, GLP-1, or DPP-4 can be continued in patients with type 2 diabetes. Other things are controversial, and in general, these are summary of the first-line medications for diabetic patients who got a COVID infection. If for patients who had no infection, but individuals who are at high risk to get the infection, as the recommendation is to follow the latest diabetes guidelines. If the patient had a mild disease and not hospitalized, the first line recommendation is the usual metformin, SGL2 inhibitors, and GLP-1. The second line recommendation is the DPP-4 inhibitors, sulfonylurea, insulin, and glycosomes are need some cautions to be used. For patient who is hospitalized with a moderate COVID disease, they have the first line is metformin and SGL2 inhibitors. Second line is sulfonylurea, GLP-1, and insulin if needed. And the third line is, or the one has to be used cautiously, is DPP-4 inhibitors. For patient who is hospitalized with a severe disease, insulin infusion is the one recommended. So we know that many of our patients, they like to use remedies or herbal medications, and there is no enough evidence for many of them. So in generally, nationally approved or over-counter medication, as well as vitamins or electrolyte supplements, may be helpful for indicated illness like headache and anxiety or documented deficiencies. And some treatments have been offered that lack evidence of efficacy or effectiveness and could be harmful to the patient. So this has to be explained clearly to the patient. Healthcare professionals has to be aware about what is patient using exactly and give them the necessary advice, and follow up for such patients with the healthcare facilities every 2 to 3 months to monitor the patients. The studies which we have mentioned regarding the long COVID disease done in MOH, similar things were also done in National Guard Health Affairs, where they open a certain clinics, which is called long COVID clinics. And this is done virtually or physically. And it has a certain guidelines and addressed in the system clearly to help such patients. This is all from my side, and I always like to conclude my lectures to remind ourselves as a healthcare professional that we have a profits. Profits, I think, mainly for healthcare workers. This is the words of Prophet Muhammad sallallahu alaihi wasallam, who said, أحب الناس إلى الله أنفعهم, and I guess the healthcare worker is most, at most at these positions. وأحب الأعمال إلى الله سرور تدخله على مسلم, and you can do this clearly. أو تكشف عنه كربة, أو تقضي عنه دينا, أو تطرد عنه جوعا, ولأن أمشي مع أخي المسلم في حاجة أحب إلي من أن أعتكف في المسجد شهرا. And I guess this is a very difficult job for any of us to have i'tikaf for 1 month, but you can do it just when you help your patients. ومن كف غضبه ستر الله عورته, and we need, this is really at the last day. ومن كظم غيظا ولو شاء أن يمضيه أمضاه ملأ الله قلبه رضا يوم القيامة. I think we all need this very, very much. ومن مشى مع أخيه المسلم في حاجة حتى يثبتها له أثبت الله تعالى قدمه يوم تزل الأقدام. We all in need for this, because it's very difficult to pass Sirat, while you can just help the patient to take him to the pharmacy to get his medication, and you will get this reward inshallah. وإن سوء الخلق لا يفسد العمل كما يفسد السم العسل. Thanks a lot for your listening.
Thank you, Dr. Samia, for this nice presentations. Now it's my pleasure to introducing the next speaker, who is Dr. Sami Al-Rahili. Dr. Sami, he is consultant of family medicine. He is the head of assessment unit in Family Medicine Academy program in Madinah. Dr. Sami, he was previously membership of examinations and trainers in family medicine at Saudi Commission for Health Specializing. Lastly, Dr. Sami also, he is TOT traders and at the same time surveyor in Saudi Commission for Health Specializing. Dr. Sami will present talk about management of obese patient in diabetes, management of obesity in diabetes patients.
السلام عليكم ورحمة الله وبركاته. صباحكم الله بالخير. بسم الله والصلاة والسلام على رسول الله وعلى صحبه أجمعين. My destiny is to talk about obesity, weight management and obesity. And for many people, including me, it was one of the worst comments to ruin your day. تصور واحد يجيك على الصبح كده يقول لك well, doctor, you increase few pounds ولا few kilos. إيش رأيكم? So, luckily for me, it was not the story now. It's changed. I managed to change that. I lost 30 kgs. I went from BMI of 31 till 24. I'm less than 80 kg. Naturally. So I will be sharing with you the ADA recommendations regarding diabetes. I will spice it up with some thoughts from family medicine and from my experience as a doctor practicing and seeing patients every day. We will have an introduction, word about human behavior change and This is the most important, and I will summarize the ADA 2023 obesity recommendations, rewording because it was very lengthy. To start with, tackling obesity and diabetes is very serious problem. Which one comes first? Some people tell obesity leads to diabetes. Others tell you diabetes will make you hungry and you eat more. But it is more complex. It is actually the coexistence of two syndromes. This cross-sectional survey was done in Bisha, and it showed in total 85% almost, or 86% of diabetics who visited the clinics there are obese and overweight. And actually, the normal weight among diabetics there was the minority, the exception. Most people were obese, more than half of them. So it is most likely for you and your clinics the same. For the sake of time, I will only show two cross-sectional surveys or studies. In Al-Khubar, it was the same story. 89% of diabetics were obese and overweight. 60% were obese. That means their BMI is high. And overweight was 27%. And this is, it's like a norm among diabetics. After seeing these two studies, I was thinking about my clinic. Almost every patient I see is obese. Actually, there are none who are normal. So why we only tackle diabetes and keep a closed eye on obesity? We need to tackle it. Inshallah, by the end of this talk, we'll see how to tackle that. The assessment pitfalls during tackling obesity, the first one and the most important one, I liked to call it planting your seeds in the thin air. Doctors are very smart. They memorize any letter which is written, any word. They keep memorizing and telling the patient the advices. But they don't know about his mindset, mentality, what he thinks. So what is the value of telling patient to walk 30 minutes per day and he thinks walking will do him no good? They will not do it. If you tell him fat are harmful for you and he thinks there are something called beneficial fat and he can consume 3,000 calories per day from that beneficial fat or olive oil, your advice will go useless. Discussing how to before the patient is ready. Not acknowledging behavior change model. As humans, we have to be Muslim before commencing prayer. We have to believe in our nation before fighting for it. So our thought is having the remote control for our behavior. We cannot change the behavior without tackling the thought, mindset behind it. The mindset. One of the famous models, and we use it in smoking cessation, weight management, starting insulin, starting lifestyle, is this model, the pre-contemplation, contemplation. It starts from this green area or blue area. Pre-contemplation. The patient is thinking about everything, or he doesn't have a thought about it. He's just living like a creature. And hungry, he will eat. Satiety or shab'an, he will not eat. He thinks, anyway, and I heard it when I was obese. What are you doing? You will die anyway. Everybody will die. Why you are tahrim nafsak? So he's thinking like that. Contemplation he's convinced that he needs to change and there is something wrong. Our role here is to tell the patient there is something wrong and this wrong need to be changed. There are benefits for change. The contemplation area or stage, he thinks, I want to get better, I want to be slim, but it is difficult. This is for others, not for me. Doctors can't control their weight. It was told to me in my clinic. I showed one of the patients my photo, and he told me, you are a doctor, I'm not. Preparation stage is when I'm determined to do it, then I will read and see how to do it. Action, he will start doing it. Maintenance, he will continue on it. I've been doing it for the last 4 years now, alhamdulillah. Relapse is the beer effect. People will tell him, يا أخي يحلفون عليك ما تقدر. أقول لهم, I rejected my mother giving me food. يعني she wants me to eat a bowl like this. He told, I'm not your mother, I'm your colleague. So you listen to me. Each stage needs certain action. If he's pre-contemplation, the answer for your advice is no. So what you will do, build awareness for the need to change. ركز على التغيير وفوائده الين هو يتغير. Tell him about قيام الليل والجنة ومنازلها, then he will pray. We cannot talk to him about walking half an hour while he's think walking will cause osteoarthritis to him. Or الناس حتقول أنا شكلي غلط, أنا شايب ما أقدر أمشي في الشارع. If he's contemplating, you pass this stage and he's telling maybe والله أحسن إن يكون نحيف. كويس ما ألبس size 50 XXL, I will wear 40. Maybe you reinforce the pros of change so that he will commence the action. If he's preparing, commit the plan. And at this stage, we need to talk about realistic goals. ما أجي الواحد عمره 70 أقول له ابدأ ب20 كيلو مشي. ولا واحد يأكل 3000 كيلو calories per day, I put him in 1000 very low calorie diet. He will starve. If you have big problem, fragment it. Commit a small change at a time. We tend to do it even in insulin. If we want to start a patient on 30 units per day, sometimes if we are not sure about the effect, we can build it up from 20 to 30 in a few weeks' time. So if he's in action, implement and revise the plan and praise, تشجيعه, because they are under tremendous pressure. Also the action, if you surround the action بطقوس غريبة, he will go to a gym 20 kilometers away with a special fit and a special time, he will not continue on that. Make it as casual as possible. Maintenance stage, integrate the change into my lifestyle. Trust me, after 3 months, it will be a lifestyle. It will be a lifestyle because we are trainable creatures. We are higher in the hierarchy than animals, but even animals can be trained. If you train your taste buds to healthy food, you'll accept it after some time. You see the babies when they are born. We give them food, they reject it. But at the 10th time, they will accept it because we trained them. When you go to Mexico and eat tortilla, or I don't know what it's called, maybe you'll not accept it the first day, but after some times, you'll find it enjoyable. This is the guideline of ADA 23. It will be commenced January 23. So we'll go through them fast. First recommendation, and it is in the chapter 8, use person-centered, non-judgmental attitude. Personal, specialized. Each patient is having a special word to be talked to him. There is nothing called one dress will fit all. So we will take his environment into consideration, and we avoid أنت متين، أنت حيجي لك مرض القلب. We tell obese persons with obesity البدانة تزيد أمراض القلب، أو أهون على النفس من أنت بدين حيجيك أمراض القلب. I remember one of my patients told me in another hospital, someone told him, you'll not reach 60 if you continue your weight like this. Maybe you will not reach 60 as a doctor. Measure BMI annually and more frequently if it is changing. And according to that, we inform the patient about treatment considerations and trajectories. Note, avoid scaring tactics. أنت حتموت. إذا خوفته, he will get depressed. And the best thing we would do when we are happy or depressed or bored is food. في العزاء food, في الفرح food, نص الليل مايونيز في bread. So avoid scaring tactics. This doesn't work, really. And it will make him miserable and hate you. And if I hate you, I will not listen to you. Check the comorbid conditions, which will make the patient more obese. If he's fluid retention because of heart failure, if he's having renal nephropathy, it needs to be addressed and evaluated. If the sudden weight changed, inpatient admission is justified for weight change, because you may think it is because of overeating, but it might be heart failure, especially if there is puffy face or lower limb edema. Privacy during weight measuring is not an option. It is a need. So many people are embarrassed. They don't want people to know their weight. And I had some patients during my youth, when I was first signed as a doctor, crying because I told them they are obese. Really, it happened in my clinic, and that changed my thought. She was with her mother, and I was advising her mother. Then I told her, why don't you do the same advice? She started crying. Weight is a big issue, especially for emotional sensitive people. So take it sensitively. بحرص شديد. طيب. Anybody with diabetes or without diabetes, they will benefit from any weight loss. Any weight loss. 1% weight loss, you will see the benefits. If it is not medically important risk factor change, it will be psychological change. What best reward when measure, other than measuring your weight and find that you are 1 kilogram less? It will make your day. 3 to 7% of the baseline weight improve glycemic control and other cardiovascular risk factors. This is scientific. 3%. For someone who's 100, if he's 97, he will have improvement in his cardiovascular risk and glycemic control. A larger sustained weight loss more than 10%, 10%. يعني في 100 كيلو 10. Usually confer a greater possible remission of diabetes. With direct study is our proof. People who sustained 10% weight loss and their diabetes is recent, and insulin resistance vanished, And they are without, for 3 years now, it is continuing. About, I think, 40%, 38% of the people are still off medication. So remission. Mortality will be improved. For our management tactics or strategy, nutrition, physical activity, and behavioral counseling is needed at any BMI, even for normal people, 20, 23. Why? Because if you don't counsel them, they will get obese later on. And for people with BMI of 40 or 30, still they need a nutrition therapy. Pharmacotherapy, it is advised from 27 to 29. After 30, metabolic surgery is considered. عمليات المعدة. By the way, the flower is to mitigate the effect of the lecture. عشان depression اللي يجي. طيب, nutrition, physical therapy recommendations, nutrition and physical activity and behavioral therapy. The aim is to achieve 5% weight loss. It is recommended to be done to achieve 5%. But it is like medication. What will happen if you give a normal diabetic patient 300 units of insulin? What will happen to him? He will run in hypoglycemia. Also, lifestyle. I am one of the people who are deceived by lifestyle that it is adjuvant to therapy. In fact, sometimes it will substitute therapy in some cases. For me, I was hypertensive 16 years. I was in Valsartan, Natrelex, and Concor, Bispirol. To my amazement, within the first month, I was off medication. My systole was less than 100. I had to visit bariatric surgery unit to tell me how to increase blood pressure after weight reduction. If you commence intensive lifestyle, it will give you more than 5%. Don't make the sky your limit. So lifestyle can give more results. Okay, additional weight loss, and this is what is written here, results in improvement in management of diabetes and cardiovascular risk. Some people lost 70 kgs. Their life changed. Their psychology changed. But they are few, and the unique are few. Such intervention should include high-frequency counseling, 16 sessions in 6 months. Yani more than 3 sessions per month counseling. And for our blessing, we have virtual counseling now. You can just talk to him in Zoom or do. And focus on nutritional changes, physical activity, and behavioral strategies to achieve 500 to 700 kilocalories per day. And for that, you need patient education. Hook him with a team, with a nutritionist. You cannot do it alone. The nutritionist will tell him that 1 tablespoon, 13 grams of olive oil, يحطها على الفول, فيها 120 kilocalories of so-called good calories. And this is equal to 3-kilometer walk. Some people think that by sport they will abolish the effect of food. يبغى يضيع أثر الأكل بالرياضة. It is food and sport. 3 kilometers can be abolished. شوفوا 154 تقريبا ملعقة. أحد يحط ملعقة على الفول. I saw people putting 200 ml of olive oil or drinking olive oil. And I chose olive oil because it's the best. مبارك ومذكور في القرآن. The nutritionist will tell you that 10,000 steps per day, or the behavioral or the doctor will burn about 500 calories, it is equal to 1 Snicker bar. واحد سنيكر يضيع عليك 10,000 خطوة، تقريبا 8 كيلو ل 10,000 خطوة، 8 كيلو لأنه الكيلو 1200. You need to know that. The patient needs to know that. The snack of 3 dates will abolish the date حوالي 60. Will abolish 3 kilometers. Our patients don't know that. They eat حتى الإشباع. And they need to know also, this is what I followed actually, 400 kilocalories of, if you want to get full of 400 kilocalories of oil, you need 1 centimeter in your stomach. If it is meat, 400 kilometers. If it is vegetables and grains and beans, you cannot eat 400 calories. You cannot, because it will make you full. And what is better than make yourself full with less calories? Number 8, individual preferences. Take it in consideration. اعرف البيئة اللي هو فيها. What is his environment? Maybe he cannot afford to buy healthy food. Maybe he's a manual laborer with shortage of money. Respect his preferences. Respect his preferences, regardless of macronutrient composition. يقول لك أبغى كيتو، أبغى أصير vegetarian، أبغى آكل أكل اللي يجي. The most important is to be healthy food. Don't judge people upon. We are judging people for their religion, location, and endly according to their food. الماكرونيوترينت you can tailor it and make it suitable for diabetic patient. And this recommendation is the strongest recommendation. Evaluate food choices. The most important takeaway message here is to be away from processed food. أي طعام معلب, stay away from it. Take food as created by God. At least you'll know that there is no additive added زي الفليفرز, SOS, salt, oil, sugar. It is abundant in everything. Currently, healthy choices are more expensive. For weight maintenance program after 1 year, continue 200 to 300 minutes per week, يعني تقريبا نص ساعة يوم أو 45 دقيقة في اليوم. And monthly contact. Don't leave your patient لأنه it's a harsh environment outside. حيقولوا له في الأخير حتموت سواء كنت healthy ولا overweight. People are tending to feel threatened when they see someone who's healthy. Long-term comprehensive weight maintenance strategy should be integrated into maintaining weight loss في الhealth. يعني يصير عندنا clinic to maintain weight. Most are healthy, no follow-up. لا, healthy should be integrated in the health system. Short-term nutrition intervention with 800 kilocalories هذا موجود. مصحات يدوا liquid diet to prove to the patient that weight loss can be happening, and short-term, because nobody will eat 800 kilocalories equal to تميزة ولا حبة شاورما مع حبة موز. Nobody will live on that. وهنا نقطة. We don't want to shift the patient from the hell of disease to hell of lifestyle, because it's either hell, he will choose the enjoyable one. I will eat, I will be happy. At least I'm in the hell with happiness. No clear evidence that supplements are effective in weight loss. Pharmacotherapy, consider weight effect on diabetes, especially minimize drugs which can increase the weights, especially antidepressants and others. Agents associated with varying degrees of weight loss, metformin, alpha glucosidase inhibitor, as SGL2 inhibitors, GLP-1s are famous for their weight reduction beneficial effect. DPP-4 inhibitors are neutral. Sulfonylureas and insulin are known to make people eat more and become weight increase. Obesity pharmacotherapy is adjuvant or adjunct. ما هي بديل. Our people think the tablet will make me slim. The cat will make me heavy. My friend will make me miserable. Never. Your misery and happiness in your head. So it is adjuvant. Adjuvant. يعني حتى اللي يعمل bariatric surgery we saw relapses in our clinics after surgery. Potential benefit and risk must be considered. Obesity pharmacotherapy is effective, typically أكثر من 5%. Weight loss after 3 months of use. The time to assess efficacy of pharmacotherapy is after 12 weeks. Further weight loss is likely with continuous use. The diabetic ياخد GLP-1, he will get benefit from GLP-1. But what if he eats more? If he quit exercising, he will get obese if he took anything. When early response is insufficient, after 3 months, or there is significant safety tolerability, other medications or treatment approaches like surgery should be considered. يعني the cut point, if the patient took GLP-1 and he's not responding, we need to not leave him alone. We need to consider something else. This is the medications. The most striking thing is that some of them lead to 10% loss, and the prices like we have oral stat, very famous. It costs for 1 month about $700. We have phentermine, we have naltrexone. It is expensive drugs. The cheapest one is lifestyle. GLP-1, we have 2 mentioned by ADA, largurotide and semaglutide. The semaglutide and the other one cost around $1,600 per month, which are expensive, very expensive. Metabolic surgery should be recommended, should be. يعني لازم تقول للمريض سوي جراحة إذا البي ام اي more than 40. Then we know for most people lifestyle will not decrease from 40 to 24. If the patient is 35 who do not achieve durable weight loss on other intervention, also it should be advised. يعني من 40 it's a must to be discussed with the patient. 35 and failure of other measures, you have to advise him to do surgery. For 30, if there is difficulty in controlling diabetes, it should be raised on the table, considered. ما هو should raised. تقول له ترى لو سويتها في patient لهم 15 سنة they are off medication or control. وهذا البنفيت حق السيرجري يمتد ل 15 سنة. Metabolic surgery should be performed in a known center يعمل عمليات كثيرة with safety, good safety profile, because it's not a simple procedure. It's not a simple procedure. يحتاج team. 21, 2 more recommendation. People being considered for metabolic surgery should be evaluated for comorbid psychological conditions. زي ما قلنا المنتال, psychology. Because some people, they run in psychological problems after surgery. They should be evaluated thoroughly. وكل outcomes حق السيرجري discussed. After surgery, they should receive long-term medical and behavioral support. وأيضا micro nutritional monitoring. يجيهم anemia, vitamin B12, malnutrition. I know a colleague who keep eating Snickers to maintain his weight, pre-surgery weight. فهذا حيجي له micronutrient أو micronutrient deficiency. The most important advice to eat protein for those people because they tend to have protein loss. ما ياكل protein. A human being needs about 1 gram protein per day from whatever sources, either meat or grains or beans. 23, if bariatric surgery hypoglycemia happens, clinical evaluation or education, medical nutrition, حتى a CGM monitoring should be commenced if there is a complication of hypoglycemia after surgery. يعني السيرجري ما هي جنة الواحد بدون if you want to lose weight you have to pay the price. So on lifestyle أو follow up with visiting clinics. 24, people who undergo metabolic surgery لازم يزوروا mental health services to help with adjustment to medical and psychological stages after surgery. This is C. And reminders, and that is the summary of my talk. Managing weight loss needs team approach. You cannot do it alone. Those who lack the skill tend to ignore the presence. إحنا كأطباء أي شيء we don't know about it or we feel not confident taking it, we ignore its existence. Time and efforts is a cornerstone for success. المريض ما يجي من أول مرة. Don't give up from the first no. You will hear so many no's and wait. With control of diabetes. يقول لك no, reject. One of my patients told me, this is not food you are talking about. Also, didn't give up after the first relapse. ينزل 10 كيلو ويتزوج أخته بنت عمه ولد خاله والكوليج and he will relapse. Start the cycle. التايم ال6 أشهر اللي أخذها وهو good weight, it count in cardiovascular and glycemic control risk. Help the patient, rescue him from perceived helplessness. أغلبنا, the problem is I cannot do it from the start. هو ما هو مستعد. But change the mindset. And thank you for your listening. And this is my talk.
Thank you, Dr. Sami, for this amazing talk. The next talk will be about the newer agents and cardiovascular outcome in diabetes. It will be presented by Dr. Muhammad Al-Balawi. Dr. Muhammad, he is a consultant of internal medicine and endocrinology in King Abdulaziz for National Guard Hospital area.
Assalamu alaikum. Good morning. طيب بسم الله الرحمن الرحيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما وعملا. Thanks for the invitations. Actually, this is my first time presenting at this conference, and it's my pleasure. We've got only 20 minutes, and it's really heavy talk, but I hope that I'll get there in time, and I apologize in advance if I'm a bit off time limit. Got no disclosure, and these are my outlines that I'm going to talk about during my presentation. For those who don't know MACE, MACE is a major adverse cardiovascular events, which mainly include cardiovascular death and fatal MI and fatal stroke. So we all know that the cardiovascular disease is the leading cause of death in diabetic patients, and actually is 2 to 3 times higher in diabetic patients compared to the non-diabetic counterparts. And despite the trend that we see in overall reductions of cardiovascular mortality, still we see an increasing number of incidents of diabetes and its mortality per year. And this is actually a new statistic with respect to the prevalence of cardiovascular disease in diabetic patients. And as you see, thankfully, compared to before 2016, you see the number is really coming down. And this concern to this with respect to the overall cardiovascular mortality, and you can see across many risk factors, the number are trending down. And actually, this includes 18% in Saudi Arabia. When it comes to the heart failure, in diabetic patients, about 9 to 22%, which is 4 times higher than the general populations. And these two comorbidities usually occur concomitantly, and each disease independently increase the risk to the other one. And whether preserved or rejection or reduced ejection fraction, with both can be seen in diabetic patients. The prevalence of diabetes ranges from 10 to 47, and we tend to see more diabetic patients among those who are hospitalized for heart failure. So we noticed that over the last 5 years or 5 to 10 years, we've seen breakthrough of cardiovascular outcome trials. And why is this? Why we are seeing a lot of these studies now? Even the focus is more moving toward the cardiovascular safety more than even the glycemic effect of these medications. So it actually was a blessing in disguise of this medications. One of the TZDs was rosiglitazone, which has been already withdrawn. And this is because the outcome that they have got, which is significant increase in the risk of myocardial infarction, the increase in the risk of death from the cardiovascular causes. And sure, that was not the outcome that we're hoping for. And this would push the FDA and other European medication agency to issues in guidance for the industry in order to assess the cardiovascular outcome in this particular patients using in your diabetic agent. And I just, it's a lot of things, actually, a lot of conditions for this program, but I would just like to mention the type of populations they needed for the assessment of cardiovascular outcome. And as you can see here, in order to assess the cardiovascular safety, you need to do it on patients who are at risk of cardiovascular disease. And as you can see here, advanced cases of chronic kidney disease, advanced stages of chronic kidney disease, established cardiovascular diseases, and elderly patients, and that needed to be included in these studies. Okay, let's dive in and talk about the GLP-1 and cardiovascular outcome. And actually, my talk is going to focus on 2 agents expectedly, which is GLP-1 agonists and SGLT2 inhibitors. And the 2 cardiovascular outcomes that I will be focusing on is heart failure and major adverse cardiovascular events, as I just mentioned. Okay, so I'm going to touch on practice-changing trials of the GLP-1s. This is a leader study that's been done on all diabetic patients. All of the patients involved are diabetic with established cardiovascular disease and with high risk factors. Sometimes it's been done on over 9,000 patients. And as you can see here, is the primary composite outcome actually is a MACE, measured adverse cardiovascular events, is achieved with about 13% reduction of this composite outcome. But we need to mention that the more driving of this benefit is coming from the death from the cardiovascular events. And as you can see here, hospitalization seems to be of heart failure seems to be safe in heart failure patients, but still is not statistically significant. And even this is not the focus of the study, so we cannot really draw conclusion out of this one. Here, you see the benefit is more driven and more for the patients who has no heart failure. But again, this is not the focus of the study. And even a small number of heart failure has been involved in this study. The other one is the one rewind for dulaglutide and over around 10,000 patients. Again, all diabetic patients established cardiovascular disease or multiple risk factors. And the finding is consistent again with the same class of medications. And you see here is around 12% reductions, and benefit is more driven by the non-fatal stroke. I brought this just for the heart rate things. They noticed that the heart rate is increased in people who've been on dulaglutide. I'm not sure whether the cardiologist is going to be concerned about this one or if significant things to them, but I think heart rate is always crucial whenever you're dealing with a cardiac patient. And as you can see, it's a pretty impressive safety profile in these medications. The other one is sustained semaglutide that we have in our institution. It's an injectable one. This is a study that's, again, for all diabetic patients, actually all the cardiovascular outcome GLP-1 when it comes to MACE is done in all diabetic patients. They are all diabetic with cardiovascular disease. They included here some heart failure patients, chronic kidney disease with certain stages. And again, it's achieved in about 26% primary composite outcome, which is MACE in this study. I would like just to mention, if you see here down in this table, the retinopathy complications actually has been observed to be worsening in people who are not using only dulaglutide. We've seen semaglutide. It's not, I think, with any medications, with any methods that you bring the blood glucose significantly, you will have a worsening of pre-existing retinopathy. So I encourage every one of us, at least before you start this medication, especially for those who have multiple comorbidities and has been uncontrolled diabetes for a long time, just have a look on the retina just before you start these medications, just to know. And actually, this is not a direct effect of the medications. It's actually because of the glycemic control that this medication has. The other thing, the renoprotective, possible renoprotective effect of this medication. Okay, this is a study that maybe most of us are not aware about. This is the only, I think, the study that they try to see GLP-1 effect on heart failure patients, and actually in this study they failed actually to show any benefit, and even worse, it's the events is more liraglutide. And with the problem that if you see here, they involve patients with recently diagnosed heart failure and even recently admitted. So actually they involve sicker patients. And this study, as you see, is a small study, short durations, and they really involve sicker patients. Talking about liraglutide in heart failure patients, this is the same goal of the previous study, but this has been done on more populations. This is done in the leader trial population, which is around 9,000 patients, but they stratify them based on the heart failure status, whether they have heart failure or not, and two outcomes being tested, which were MACE and hospitalization. As we can see here, it's consistent with the leader study. We see the improvement in the MACE overall, and it's not affected actually whether they have heart failure or not. And the other outcome is hospitalization of heart failure is the contrary to what we have just seen in 5 studies. Actually, it seems to be safe in heart failure patients. So the crucial questions here, we see statistically significant finding, but this doesn't mean always clinically significant. And these studies being entitled to do it in certain populations. And this might not be, it's maybe difficult sometimes to translate it into your clinical practice. And I would just like to mention these 2 points here. You see the prevalence of cardiovascular disease across these different trials is 181, 72, 73, and it's unlikely that you will have 70 to 100% of your patients having cardiovascular disease. And actually what we see is like more of 30, something like this. That's why the rewind among the others is more generalizable, because this is the percentage that you will most likely see in your clinical practice. The other point is here, prevalence of heart failure in this is very small number that you cannot really draw conclusion out of this one. And we need more trials focused on this type of populations in order to see if there is really any benefit or not. This is one of the ways that we can translate the trial's outcome into our clinical practice, is having more real-world evidence and to see if this is really applicable and this is the same. It's going to be, is it going to be consistent to what we see in the trials? And this is one done in with liraglutide and assessing cardiovascular and real-world type 2 diabetic patients. And as you can see here, is actually liraglutide is doing a pretty good job in real world compared to leader study, but still this is not statistically significant. And unfortunately, the events is even higher in people who have established cardiovascular disease. And this is not what we have seen in leader study. And this event has been increased even if they are in liraglutide study. Another study, this is, as you see, is observational. It has a lot of bias, monocentric and small study. This is another study that's been done in Cleveland Clinic of over 100,000 patients assessing GLP-1. The two GLP-1s assessed here is exenatide and liraglutide. And as you can see here, for people who have been using GLP-1, we see a statistically significant benefit in terms of composite outcome, which is amazing. CVAs, all-cause mortality, and it's neutral when it comes to the acute myocardial infarction. So we're seeing even heterogeneity in the finding, even with real-world evidence, but it seems to be more consistent with the trials. This is another one, exenatide is done twice daily, and this is the cardiovascular disease. And you see with different methodology used, still is around 14 to 20% reduction in the cardiovascular disease. Here's the meta-analysis that included 8 trials. Total of patients is about 60,000. And as you can see, the finding is always consistent in favor of GLP-1 agonist. But I would just like to mention here, Alexa study is something that need to be mentioned. We didn't see such benefit here, but actually what's make this study different than the other study that they included really sick patients. In recent MI, their patients are sicker than the other study. I think it's unfair to compare this to the another one. Okay. Let's switch the gear to SGLT2 inhibitors and cardiovascular outcome. The first study is the empiric that used empagliflozin in over 7,000 patients. And again, the same outcome is being tested here, which is MACE, and all diabetic patients, cardiovascular disease or risk factor. And as you can see here, it's about 14% reduction in the primary composite outcome and the hospitalization. But this is not the primary composite, this is a secondary outcome. You see really significant improvement in this regard with almost 35% reduction. But again, this is secondary point, is not the primary focus. Here you see a hypothesis generating of other studies to really look at the SGLT2 inhibitors on these populations, heart failure populations. Another study is CANVAS, canagliflozin, on all diabetic patients, cardiovascular disease. And again, the finding is consistent with about 14% reductions in the primary composite outcome. So extra things here, the hospitalization, again, we see the benefit in this part of populations, in this agent, and the renal protective. And I think my colleague, Dr. Shaib, will touch on this one in his talk, probably. Okay. Dapagliflozin, declared time-based study. It's done also in diabetic patients with cardiovascular disease. And this is the only study that used dual primary outcome, which is one for efficacy and one for safety. And both were hit with the statistically significant we see here in cardiovascular death and hospitalization as a primary efficacy. And for safety and efficacy, it seems to be efficacious and even safe. Sorry, but you see here, when it comes to MACE, you see really is more moving with almost all subgroups is moving toward the dapagliflozin, but we see it's more consistent and more clear here when it comes to the heart failure. So we can't just say this is really safe when it comes to MACE, but even efficacious when it comes to heart failure. Again, this is a table just showing to you, you see the prevalence of cardiovascular disease in those patients, and this makes them less generalizable to our routine care. And this what makes dapagliflozin in this, declared time is more easily translated into practice when it comes to how the type of populations. You see the MACE outcome is being achieved in almost all of them with around 14% reduction, and hospitalization is consistent across all the studies, and even renal composite outcome is being assessed. Just to mention here, Credence is focused on the renal outcome, and DABA heart failure that we will touch on very soon the main focus is the hospitalization. Moving to the heart failure thing. DABA heart failure studies been done in over 4,000 patients, assessing the worsening of heart failure and cardiovascular death. And as you can see here, it's actually 26% reduction. This is a large improvement in these parameters. And this is primary comes when it comes to the heart failure is actually 30%. So this medications from the first time you review the study, you see how significant. And one thing I will show it to you in every heart failure study that you will observe is the early split of the lines. So the benefit you will see it earlier upon initiation of the medication. What I observed while reviewing the study is most of the patients involved with the study are class 2 heart failure patients, and less advanced heart failure is being involved in I think across all the heart failure studies. And actually some of them, they excluded advanced heart failure patients, maybe just for safety issues. This is the empagliflozin has been done specifically in reduced ejection fraction heart failure. And again, the same outcomes we see here is about 25% reductions, the primary composite. And the secondary endpoint is the overall heart failure, including the first and the recurrent, and doing even better in this goal with 30% reduction. Again, the same thing, you see most of the patients, about 75% are class 2 NEHA heart failure, and less we see with advanced stages. What's really impressive here, if you see, is only 50% are diabetic. So this medication is not only working for diabetic patients, but even non-diabetic patients. So I don't think that they will call it in the future. They will check the name of the medications as diabetic medications. Here, as you see, is small number of patients, or whether diabetic or non-diabetic. You see there is a statistically significant when it comes to the heart failure and cardiovascular death. Again, here you see there is no statistically significant when it comes to the advanced heart failure, but again, this is very small number involved. And I think if they involved more patients, that the result could have been totally different, and more patients maybe. I think with the finding we have just seen, there will be a benefit. This is the sotagliflozin studies. It's actually SGLT2 1 and 2 inhibitor. It's not only one. is not only two. And this is what's different about this study compared to others is this is the only SGLT1 up until that point that used in acute heart failure patients, was not usually used in acute heart failure patients. And again, they excluded in stationary disease, and see how impressive this medication is doing really in this population. And they give the medications actually just few days just before discharge or 2 or 3 days post discharge. And you see here, what's really striking is the number needed to treat is 4. So you need to treat 4 patients for one of them to get the benefit. This is impressive, and we don't usually see such numbers in most of the clinical trials. As you can see here, the benefit is even consistent with people who have ejection fraction more than 50, although the number is less than of those who have ejection fraction less than 50. But this would encourage more investigators to see the effect of these medications on people who have preserved ejection fraction, because actually we have seen both reduced and preserved ejection fraction in diabetic patients. And that's why it comes the empagliflozin studies done on heart failure with a preserved ejection fraction. The same thing, early changes early in the study, and it really is about almost 20% reduction in hospitalization and cardiovascular death. Here again, most of the patients are NIHA class 2, and the same thing here. You see is almost 50%, or even less than 50% were diabetic. Here, dapagliflozin, again, with the same type of populations, preserved ejection fraction heart failure. And across all the parameters, the finding is really consistent, ranging from 20 to even higher reduction in the heart failure and cardiovascular death. So this is a systemic review involving almost all of the SGLT2 inhibitors. But here, what's been really fascinating is they classify it into whether they have heart failure, or they don't have heart failure, into outcomes. And as you see, whether they have heart failure or they don't have heart failure, the finding is really positive and impressive. When it's come to the heart failure hospitalization, expectedly you see significant improvement. So this medication is actually working a really wide spectrum of patients, whether diabetic, non-diabetic, who have heart failure or not having heart failure. This makes us thinking that there might be working really in prevention of heart failure. These are, I'm not going to go through them, but just to because when you see every study is encouraging and really showing optimism of these medications and pushing us more and more to do in more type of populations. And this is two studies that have been done on acute heart failure patients, the same that we see with sotagliflozin. So medications that have all these effects should have many way of doing so. And as you can see, here's a lot of mechanisms that's mainly driven from the glyceric effects and natriuretic effect. And I think the diuretic effect or glyceric effect, this is the force that led to the early changes that we see it in the earlier in each trials. We used to say always broad spectrum antibiotics, but I think we have a broad spectrum anti-diabetic, but I think it's not only for diabetic patients. And you see it's working in diabetic, non-diabetic, recently diagnosed chronic heart failure, stable or acute decompensated heart failure, even if they have or they don't have heart failure. And I think very soon chronic kidney disease patients will be involved in this, because still more and more study. I think there are some ongoing into advanced chronic kidney disease patients. This is simple guidance from American College of Cardiology. It is always person-centered, patient-centered approach, and it depends on your goal of your patients. If your patient's having heart failure, chronic kidney disease patients, you would prefer SGLT2, but always pay attention to the complication and talk to your patients about the possible complications. But at the same time, you should tell the patients why you are using these medications as an encouragement to the patients to be compliant to medication. Because as a patient, as a human being, actually, we tend to look at the negative side, not the positive side of anything. Before I finish my talk, I would just like to mention something belongs to us as a physician. This is a International Diabetes Federation that's done a survey from 2017 and 2018, and they're trying to see how aware of our patient of diabetes as a risk factor of cardiovascular disease, and how are we doing as a part of counseling and bringing the patients awareness to these things. And this involved 33 countries, including Middle East and Saudi Arabia. You see here, it's actually deceiving numbers. And when it comes to the discussion of type 2 diabetes as a cardiovascular risk factor with our patients, is only 25% have discussed diabetes and cardiovascular disease with their patients at the time of diagnosis. And actually, this is really, really small number and really deceiving to see such numbers. When it comes to the last time they discussed cardiovascular risk, is you see 21%, only 21% have discussed it over the last 6 weeks. And such things should not be only discussed with the first visit. It has to be discussed over and over again so the patients digest and understand the importance of this medication and why we use them. Sometimes the patients will be compliant more if you tell them why you are using the medication. And this is in Middle East, actually, and you see how our patients aware of diabetes as a cardiovascular risk factor is only 50% aware that diabetes is a cardiovascular risk factor. And before we pushing the patients to be compliant with medications and blaming them, and I think we should just do a bit of our job to counsel patients and tell the patients what are the possible complications. And before that, you need to encourage him. I mean, you don't only focus on bad things, but also an encouraging thing. The take-home message here is, as you see here, overall GLP-1 and SGLT2 inhibitors are really safe medications and efficacious in most part of the cardiovascular outcome. SGLT2 inhibitors work across a wide spectrum of clinical scenarios, and always unfair to compare. This is not only applicable to our presentation here, but all clinical trials, because different trials, different populations, limited criteria, and different design. And real-world evidence is needed to assess the applicability of the trials in all routine care. And although it seems to work, more patients with advanced heart failure need to be involved in future study, and we must do our part before blaming patients or when it comes to the counseling and awareness. Thank you. Thanks for your attention.
Thank you, Dr. Muhammad, for this nice talk. Now we are going to the answer and the question panel. Please, the speaker of these sessions come on the stage for answering questions. If anyone have any questions, please raise your hand. Dr. Sami.
Assalamu alaikum. Question for Dr. Balawi. Mashallah, excellent talk. Just one question regarding the GLP-1 agonists. Is that effect, in your opinion, dose dependent, or is it just a class effect that if you just initiate on the initial dose, that would be enough to cause cardioprotection?
Thank you, Dr. Shaib. I think this is really good questions. From our clinical practice, I think it's really difficult to assess this because it's short time until we get to the maximum dose of GLP-1 agonist. But if you notice in the studies, usually they have one dose is being tested, and actually most of the time is the maximum dose, and they have protocol to go up until the maximum dose. So I don't think I can't tell you exactly whether a small dose or not is really affected achieving the goal of when it comes to the cardiovascular outcome. But what we have seen is the higher dose, and actually we go up, as you know, is more of tolerance thing than the efficacy things.
Any other questions from the audience? We have a question for Dr. Sami. Dr. Sami, as you mentioned in your nice talk about the high prevalence of obesity in Saudi populations, from family medicine aspect or from us at our administrations, did you have any suggestion programs as outlines for decrease this very high, huge prevalence?
For the statistic I presented, it was especially among diabetics, but we know that obesity and overweight are prevalent, and this is taken in consideration. If you compare Medina, for example, Mamsha, walk areas, and pushing people to walk compared 10 years from now, it is different. The mention of calories and food labels to help us take at least informed decision, it is a legislation now. في تنظيم لها. At least I need to know my calories. What is lacking still is the help groups. We tend to see the help groups in the West where we provide formal non-official help to patients who are seeking help, like what is happening in quitting smoking right now. I don't think obesity is receiving the same attention in the media because it is legal. It's not like smoking. People are benefiting from obesity. وتوافق هوى. People tend to indulge in their joy. So help groups, and the start point is to tell the patient that you are obese. Measure the BMI. What we call it opportunistic health promotion. Someone bringing his child to vaccinate him, and he's obese, or she is obese. It's worth that you discuss the issue with her. الزن يكسر الحديد ولا الدق يكسر الحديد. Really, the family medicine is all about frequent contact with the same message. If they heard the message from you, from Dr. Samia, and from me, and from others, they will most likely to shift from pre-contemplation to contemplate. Well, ما هو معقول كلهم على خطأ. Organized work with all sectors. الشؤون البلدية والقروية alone cannot take the burden alone. Physicians and جمعيات خيرية. عندنا أظن في المدينة جمعية الصنع أعتقد ولا؟ I don't know. If it is there, if it is not, we need to at least build it up or plant the seed for it.
Any other question? Last questions, please. The back.
My question is to Dr. Mohammed Al-Bloui. Um, as both SGL2 inhibitors and GLP-1 agonists have a cardiovascular benefit in diabetic patients, which other patient factors should be taken into account to select the best option other than renal function? Thank you.
Excellent. And actually, don't forget that these medications really doing great job in terms of hemoglobin A1C reductions and losing weight and weight reduction. That's really motivational to many patients. And this is actually the main factor that keep the patients taking these medications, because of the weight loss that they observe during this medication. If you remember previously, the focus was, even if it's patient-centered, was focused on the glycemic control, but now is more of a cardiovascular outcome trials and cardiovascular outcome and obesity and chronic kidney disease patients. I think what you have just mentioned is the main driving factors of initiating these medications, actually, even as a prevention or secondary or primary prevention. I think answering to your questions, how bad is their glycemic control, how obese they are, I think these are two factors that has to be added to the cardiovascular benefit and the renal protective benefit that we've seen.
By this question, we came at the end of this first session this day. We will have 10-minute break, then we will start the second
في
session.
سؤال هنا.
We can't take the answer at the break time because we have limited time.
Assalamu alaikum wa rahmatullah. We will start the next session, inshallah, about cutaneous manifestation of diabetes with Dr. Bushra Salah al-Raddadi. She is having Saudi, Arab, and European board in dermatology, and she is a trainer in the dermatology Saudi program in University of Health.
Assalamu alaikum. Yeah. Okay, to start with, diabetes, as we all agree, is a systemic disease with clinical manifestation that affects almost every organ system, and clearly the skin is no exception. Now, cutaneous manifestation of diabetes may not be life-threatening, but they serve as an important external marker for internal complications, as well as they can affect the patient dermatology, like the quality of index, tremendously. And with diabetes being epidemic, I believe that a multidisciplinary approach and care to the patient is important. And that's why we should involve different specialties to exchange knowledge and experience. We can classify the dermatological manifestation of diabetes into dermatosis associated with the disease, like pruritus, necrobiosis like lipoidica, granuloma, annulari, and others, as we will see, and those associated with as a complications with the disease, like eruptive xanthoma, perforating dermatosis, diabetic foot, and limited joint mobility. And then we have the increased susceptibility to infection, whether fungal or bacterial. And lastly, we have those dermatoses related to the treatment, whether oral hypoglycemic agents, insulin, or even in the glucose monitoring device. Starting with those associated with diabetes, pruritus being among the commonest we see in the clinic, and it can considerably impair the quality of life. We have two forms of itchiness, either the patient complaining of generalized itchiness or localized, and if it's localized, it's usually perianal and in the genitalia. The patient may not have any skin lesion, or he can only have dry skin, or it can be as severe as having, like what you see in the picture, prurigo nodularis. And this pruritus is attributed to the polyneuropathy and cirrhosis they have. This can be minimized by normalizing the glucose to moisturize the skin. And if there is no improvement or it is severe, we can use topical corticosteroid, topical capsaicin, and oral antihistamine. If it's refractory to all this, we can try phototherapy in the clinic, where the patient comes twice or 3 times per week to take narrowband UVB. Microbiosis lipoidica, it's not very common, but it's common among dermatologists. When we diagnose microbiosis lipoidica, we have to screen the patient for diabetes. What we see is almost always peritibial, annular erythematous plaque, and the central atrophy is characteristic. They have the yellow hue and they have the blood vessels, the telangiectasia, very clear. Here are different stages of the same disease, ranging from mild to severe. They even say in one study that if the patient is diagnosed with microbiosis lipoidica and at the time of diagnosis he doesn't have diabetes, he may develop it later. It has nothing to do with the glycemic control. And a minority of patients may have spontaneous resolution, but we don't leave the patient untreated as he may develop ulcer. We treat with topical potent steroid or intralesional steroid. Granuloma annulare is another common disease we see with diabetes. It is asymptomatic, have different morphologies. The most associated with diabetes is the generalized disseminated type, as we also screen the patient if we have disseminated granuloma annulare for diabetes. If the patient is having just one and localized, you can leave it untreated, but if it's generalized, we can treat it with phototherapy, dapsone, or isotretinoin. Scleroderma typeticorum is when there is induration and erythema, mostly on the upper back and the nape of the neck. It's usually non-pitting, and it is due to accumulation of collagen, either by irreversible glycosylation of collagen and making it resistant to degradation, either by the hypoxia and microvascular damage the diabetic patients have, which leads to increased collagen deposition and mucin. It's usually asymptomatic, but it bothers the patient. And management can be quite difficult. Phototherapy can be tried. This is a very common, we see on daily basis, acanthosis nigricans, where there is hyperpigmented velvety plaque on the folds, axilla and groin. We can see it also on the hand and submammary areas. It is linked to overweight, hyperinsulinemia, but it's also seen with carcinomas like the stomach and the secondary medications, nicotinic acid, estrogen, and corticosteroid, and other endocrine abnormalities. Treating the underlying cause is the mainstay of treatment. We advise weight reduction, controlling the hyperinsulinemia. Topical doesn't improve the condition, and some doctors give systemic and topical retinoid. I don't advise it as it is irritant. Diabetic bully is a painless bully that usually appears acral in the feet. It is tense with sterile fluid inside. It's not inflamed, and it spontaneously heals, but it can bother the patient and cause a discomfort. So we might aspirate the fluid with a needle, or we just puncture the bully from the lateral side and then evacuate all the fluid. The patient will feel relieved immediately, but leave the skin overlying the bully there to serve as a biological cover, and use a topical antibiotic. Moving toward complications of diabetes, we have the limited joint mobility, which is called diabetic cheilorarthropathy. This is caused by thickening of the skin over the joints, and the same mechanism in scleroderma typeticorum. We have 2 tests to do it. We have the prayer sign and the tabletop test. Here you can see there is like a gap between the 2 fingers. Here's the affected hand, and here's a normal hand. Here also affected joints, and here's the normal hand, can lie flat on the top of the table. Same mechanism as we said before, abnormal collagen deposition. It is associated with retinopathy, nephropathy, and the duration of diabetes. And there's one old study claimed that 2.45-fold increase the risk of limited joint mobility with every hemoglobin A1C unit increase. Usually when it happens, it's irreversible. There's one case report that it was reversible after a pancreatic transplantation, and another study afterward explained that resolution because of the treatment with corticosteroid. Patients should go under physiotherapy to improve the function, and injection with corticosteroid might help. Penicillamine, as it inhibits the collagen and cross-linking, may help also. Diabetic foot, it's estimated that a diabetic patient have a 10 to 25 lifetime risk to develop foot ulcer. And this is multifactorial due to the peripheral neuropathy, vascular disease, and combination of both. What we see as dermatologists in the clinic is the neuropathic ulcer, where there is callus around the ulcer, and it's usually painless, unlike the ischemic one, which is painful end of the dorsum of the feet. What happens is the neuropathy they suffer from will lead to foot deformity and abnormal pressure over the bony prominence. This will lead to callus formation, and this will lead to a repetitive injury, local tissue injury. Then the callus will get out and leaving an ulcer. What we hope is to prevent it from the start. As you refer the patient from this stage, we can do the callus removal. This is when we debridement. And this is the callus removed, facilitating healing. Diabetic dermopathy, it's a pre-tibial also, asymptomatic, bilateral atrophic and hyperpigmented round and oval macules, diagnosed clinically, no need to treat it, but investigate the patient for retinopathy and peripheral neuropathy. Perforating dermatosis is very common, where we see keratotic papules that is primary on the extremities, and it is strongly associated with diabetes and chronic kidney disease. The treatment can be challenging. We start by controlling the hyperglycemia. We use topical corticosteroid or intralesional. We might start the patient also on topical keratolytics. Phototherapy can sometimes help. Eruptive xanthoma is seen in association with diabetic dyslipidemia, where we see red-yellow papules appearing over a rapid period. And there are case reports of eruptive xanthoma being the initial sign of diabetes. This is one, and this is another. Eruptive xanthoma is associated with hypertriglyceridemia over 2,000. And the treatment should be lowering the triglyceride, and it will go. Moving to cutaneous infections that is associated with diabetes. We all know the barnacle and carbuncle, usually caused by Staph aureus. It can and cannot be associated with systemic symptoms such as fever and regional lymphadenopathy. Warm compression can help, but the mainstay of treatment is incision and drainage and systemic antibiotic. If it's resistant to systemic antibiotics, then think of MRSA. If it's recurrent, the patient can benefit from eradication of Staph aureus from the nose, axilla, and perineum. Malignant otitis media, usually caused by Pseudomonas aeruginosa, managed by the ENT with IV antibiotic phonoloids. Erythema is caused by gram-positive Corneobacterium lentispum. We see reddish, scaly patches in the inner thigh, web space, and in the axilla. And this can be identified easily in the clinic with the Wood's light, where we see the poral red fluorescence to differentiate it from fungal infection. Treated with topical antifungal, topical antibacterial, clindamycin, and 20% aluminum chloride to manage the hyperhidrosis. If it's resistant, we can start oral erythromycin. Candiasis, oral thrush, and the trigo can be also managed with topical antifungal if resistant, oral. Tinea pedis, very common, and the interdigital tinea pedis is the most common of all types. There is a pruritic erosion and scale, usually in the last web space. And if it's associated with fissure, it can be very painful to the patient. Treatment is with topical antifungal. If failed, we start systemic. And also you have to educate the patient about the recurrence. It has a high recurrence rate. Advise the patient to use breathable footwear and socks. And also use the antifungal powders in the feet, on the feet and in the shoe. Here are different topical antifungal agents that can be used. And if there is involvement of the nail in any type of antifungal, don't use topical, start with systemic right away. Lastly, we have the dermatosis related to treatment. We have the cutaneous reactions of insulin. We have them immediate, delayed, and lipodystrophy. The immediate can be the urticaria, angioedema, and anaphylaxis, and this is rare. Then we have the local reaction, erythema, and pruritus at the site of injection. Delayed hypersensitivity can be reaction at the site of injection, borbiliform adjuvant exfoliative dermatitis, which is rare. Lipoatrophy and lipohypertrophy is there and it's common. This is the lipohypertrophy and lipoatrophy. This is reaction at the site of injection. You can see the erythema and the duration, and this is abscess from the insulin pump therapy. We have to tell the patient to rotate the site, and also to inject intradermal. Sulfonylurea can be associated with multiple skin reactions, ranging from photosensitivity, allergic reactions, lichenoid striaform. And usually, if they develop skin rash with sulfonylurea, they will develop it in the first 2 months. DPP-4 inhibitors are linked to a very serious disease, bullous pemphigoid, and the literature is writing it recently. And it's estimated that 10-fold elevated risk of bullous pemphigoid after the use of vildaglip. This is the bullous pemphigoid. Angioedema is also associated with DPP-4 inhibitors, but only if combined with the ACE inhibitors. GLP agonist. 20% of patients who use them, they report injection site reactions, but they are usually transient, erythematous, and mildly itchy, and not requiring changing their medication. And it's more frequently with long-acting than with short-acting. SGLT2 inhibitors, the most cutaneous side effect is cangiasis, and vulvovaginal cangiasis also, and 10% seen with the patient, but it's mild, episodic, and can be easily treated with oral antifungal. The cutaneous reaction to diabetic devices, there's one study in 2016 that showed 8% of the patients having these allergy from freestyle Libra sensors. And it's usually due to the adhesives, an allergen called isopronyl acrylate, and this can be diagnosed and confirmed by a skin patch test. Here's a severe reaction to the same allergen reported in one of the cases. Same also reaction and confirmed by skin patch test. Another one, allergen in the adhesive, it's called clophonium, and it's also can be confirmed by skin patch test. How to avoid this is by instructing the patient to insert the device on a clean, dry, septic, and if they have long hair, to trim the hair before. And if they still develop this reaction, they may, there's in the market barrier films, they can put it between the device and the skin. Thank you.
Thank you, Dr. Bushra, for this informative and nice lecture. Now we'll move to pediatric age group and diabetes with Dr. Abdelhadi Habib. Dr. Abdelhadi having MRCB, FRCB, and he is the chairman of pediatric endocrinology department in Prince Mohammed bin Abdulaziz Hospital.
Thank you very much, Dr. Arish, and good morning, everybody. It's my pleasure to be with you this morning. It's the first time for me to attend this conference. I was a little bit surprised that pediatric diabetes was given just 20 minutes out of the whole program, but I hope this will improve next time. While waiting for the technology to go up, yeah, can you just set up the technology for me? I think it must be for just load it this morning. Yeah, it was loaded individually. Diabetes hopefully this time will not be taken from my 20 minutes. But anyway, I think when we talk about pediatric diabetes, we all know that the majority of patients or pediatric patients with diabetes have type 1, which, as you know, it is an autoimmune destruction for the beta cell. But over the last few years, or I say the last few decades, and with the rising prevalence of obesity, we started to see patients or pediatric age group patients developing type 2 diabetes. I think as the time goes, the picture became very blurred. So you can't really be sure in certain patients whether this child has type 1 or type 2 diabetes. And some people start to using the term 1.5 diabetes, or maybe type 1 diabetes B, etc., whatever you like. And I find it very difficult, really, sometimes, particularly with obese patients who have autoimmune positive. And then we started to see more patients with diabetes due to genetic defect. And that's what we call monogenic diabetes, i.e. diabetes due to a single gene defect. And the best example for this type of diabetes is maturity onset of diabetes, which is being covered yesterday, I think. There's also neonatal diabetes and a number of syndromic diabetes. And as the time goes and we start to see the survival of childhood cancer, we started to have more patients with what we call secondary diabetes. And these are diabetes caused by medications such as steroid or some chemotherapies like asparaginase, and patients who have diabetes due to chronic illness. And the best example for this here in Madinah is thalassemia, sickle cell, and in other areas, cystic fibrosis. And what I'm going to do is just to take you through a quick journey covering these 4 forms of diabetes which we see in children. And I will take it as, or try my best really to take it as a case scenarios. But before that, I just let you know that around 1 million of children worldwide suffer from type 1 diabetes. So if we talk about 8 million individuals with diabetes, 1 million of them are a pediatric age group. And what makes things worse is that this number is on the increase, as we see at least 100,000 of newly diagnosed diabetes every year. If we look at the worldwide incidence of diabetes, you can see here Saudi Arabia in the red zone with among the highest countries with high incidence of type 1 diabetes, ranging or above the 30 per 100,000 figure. Now, you'll be surprised that the figures from Saudi Arabia is just based on 2 studies. One of them conducted in this city, we did a long time ago, and it showed that our city has one of the highest incidence of diabetes, not only in the kingdom, but worldwide. And this figure of 29 per 100,000 confirmed also by another study from the eastern region, which showed 27.5. But of course, this is a study in just one of the Aramco camps or Aramco population in the eastern region. So diabetes is common here, type 1 diabetes in Saudi Arabia, and we got the evidence. Diagnosis is usually easy because the majority of patients will either have some symptoms, polyuria, polydipsia, and we know all this, and they present with high blood sugar. So you don't really need to struggle to make the diagnosis. Maybe in asymptomatic cases, particularly in non-type 1 cases, you can see patients with just accidentally have a high blood sugar or high hemoglobin A1C. We don't really rely a lot in pediatric practice on the 2 hours or the glucose tolerance test in general, but sometimes we can use it in suspected cases. Now, a good number of our patients present with diabetic ketoacidosis at onset, and this really reflects the lack of awareness or the limited awareness of pediatric symptoms. And this is not just in Saudi Arabia, it's worldwide. And you can see here there is a variation between the prevalence of or the frequency of diabetic ketoacidosis at the onset, ranging between 10% to up to 90 to 93%. And here I got Medina based on data in 2005, where we showed that 55 or almost more than 50% of our patients with diabetes present with diabetic ketoacidosis and compared to other areas in the kingdom. So there is a variation even within the kingdom. And I think this is very expected. Now, the good news is we were able to drop down or to reduce the frequency of DKA following an awareness campaign. And you can see here the rate dropped from 55% to 45% over a period of 10 years. And I think this is a major achievement. So the diagnosis is easy, but mistakes can happen. And I'll take you about the story of this young man who was referred to the maternity and children's hospital at the age of 9 years. He was seen in one of the private hospitals with vomiting and abdominal pain, dehydration, tender abdomen, electrolytes fine, blood glucose was not done. And the child was diagnosed to have appendicitis. So appendicectomy was done. And the operation went fine. The scar was not bad, all under aseptic technique, as you can see. But post-operatively, the child did not wake up. And when the nurse in the theater checked the blood sugar, it was very high. So in fact, this child has diabetic ketoacidosis, which can present with abdominal pain. But he was diagnosed as acute appendicitis and had unnecessary surgical procedure. Fortunately, he recovered after he was transferred to the maternity and children's hospital and was discharged home without any complications. Another girl, 10-year-old, abdominal pain and vomiting. Again, she went to one hospital, private hospital, where the physician thought, or the surgeon thought she might have something wrong with her tummy. So they suggested endoscopy, family refused. Went to another hospital, they were more clever, they checked the blood sugar, high, pH low. So they made a diagnosis of diabetic ketoacidosis and transferred the child to the maternity and children's hospital. The same thing, the same findings were confirmed at the maternity and children's hospital. A loss of glucosuria, but just 1 plus of ketone, and the impression was diabetic ketoacidosis. So the girl was transferred to the pediatric intensive care, and she had the necessary or the usual management of diabetic ketoacidosis. 8 hours later, everything improved, but the child continued to be in pain. So there must be something else. So we called the surgeon, and the surgeon did urgent laparotomy, and you can see here twisted bowel, gangrenous, operation went fine, and the scar was okay, but the girl lost the majority of her bowel. And this girl, in fact, had stress hyperglycemia due to mid-gut volvulus. So it wasn't really diabetic ketoacidosis. And the hint here that there was no symptoms, because this girl has no polyuria, polydipsia, and A1C was not checked. So we can say the diagnosis of diabetes is simple, but mistakes can happen, and these are just an example. So my message is to remember that DKA can be similar to acute illness like appendicitis, pneumonia, or even bronchiolitis, particularly in this season. So if you've got a child with tachypnea, don't just assume this is bronchiolitis or pneumonia, even during the COVID crisis. So it's better or good practice really to check the blood sugar. The other thing is, if you think the child has got appendicitis and you, before sending the child to theater, you really need to check the blood sugar. Thirdly, severe sepsis and peritonitis as well as convulsion can cause transient hyperglycemia, which is not diabetes. And I showed you an example of the girl who underwent the laparotomy and found to have twisted valve. Now, the management of diabetes or childhood diabetes follows the same thing. There are lots of guidelines. This is the most recent ISPAD, or the International Society for Pediatric Diabetes guidelines, just published a month ago. And I was very proud to be one of the co-authors in these guidelines. It's a full chapter. It's very easy and very cheap. You can just go through the line and download the whole things. But in summary, it is a hospital-based. So you really need to refer any child with suspected diabetes to hospital as soon as possible. Symptomatic hyperglycemia is enough for making the diagnosis. No need for glucose tolerance test. We don't really do it in pediatric practice, only occasionally. And as we all know, the management of diabetes and any other chronic illness is multidisciplinary, including different people. And the main focus is education, exercise, using the right insulin for the child, and the dietary management. Oral hypoglycemic agents, we heard about them a lot this morning, but their use in pediatric age group are very limited. Only few cases with monogenic diabetes can be better managed by oral hypoglycemic agent. And of course, type 2 diabetes in pediatric age group will be better managed with oral hypoglycemic agent. But you need to remember that not all children with diabetes have type 1. Yes, the majority have type 1, but not all of them. This 8-year-old girl was referred to me a few years ago with obesity and hyperactivity. She also has some developmental delay. The father has type 2 diabetes for more than 10 years. She has no polyuria or polydipsia. And you can see here, she's very overweight. Her blood glucose was 35 millimole, and this is in the clinic, A1C 11.2. And you can see here, she has evidence of acanthosis nigricans, blood pressure high, hyperlipidemia. So the diagnosis is very straightforward, type 2 diabetes. But the main thing you need to remember is type 2 diabetes in children can be, or usually, asymptomatic. And I think it's the similar case in adult as well. Now, this girl was given metformin, which is our first line of management beside the lifestyle and dietary modification. And 3 months later, we were able to reduce, or she was able to reduce her weight by 10%. And this was accompanied by improvement in her hemoglobin A1C, blood pressure, as well as the lipid. Now, this is just an updated one of the chapters in the ISPAD diabetes guidelines, recently just covering the type 2 diabetes. And it is, I put here, Middle Eastern or Arabs really are one of the nations or one of the ethnic groups who are more predisposed to type 2 diabetes. And the main management is lifestyle modification, metformin, and sometimes we need to give some of our patients insulin temporarily to bring the hemoglobin A1C. And the criteria for diagnosis is more or less the same, like adult. I'm not really going to spend more time on it. Now, what data we have in Saudi Arabia? There isn't really a good national study on type 2 diabetes. What I found here is a very nice work done by my friend Abdul a long time ago. And what Abdul did and his colleagues is looking at a good cohort of children with a high BMI or slightly overweight, I would say. And those of them who had hyperinsulinemia, he measured their hemoglobin A1C, fasting glucose, and also performed glucose tolerance tests. There's a lot of work involved in this study. And you can see here the prevalence of type 2 diabetes among this cohort was just under 10%. So if you look at a specific age group, and the prevalence of type 2 diabetes is high, particularly in the overweight. And I'm sure if we repeated this study anywhere, we'll probably have something like this and even more. Right, so type 1, type 2, We got two other forms of diabetes, and I'll just take you through the story of this 7-year-old who was referred to me long time ago. He was, his mother was measuring his blood sugar because his father has diabetes and his grandfather and grandmother also has diabetes. And what was interesting is his father had diabetes at the age of 33 and was raised as type 1, but yet he had evidence of retinopathy at the diagnosis, which is unusual for type 1 diabetes. So this boy's got glucosuria, but he has no ketonuria. His BMI was fine. He had no acanthosis, A1C 7.1. He was seen by his father physician, who performed a glucose tolerance test and confirmed that his blood glucose was high at 120 minutes. So there was no doubt that this child also has diabetes. He was given dietary advice, small dose of insulin, but 3 months later, nothing changed. And in fact, his A1C has risen. He was referred to our clinic, and on further assessment, he had no extrapancreatic feature. His C-peptides were fine, and his autoantibody were negative. So we said, is this really type 1 diabetes? Could be type 2. Unusual, because he has no acanthosis and he has normal weight. It could be early onset MODY, and I'm sure you all heard yesterday's talk about about MODY in general. And in fact, when we sent direct sequencing for the hepatic factor 1 alpha, it confirmed that this child has a rare form of diabetes, which we call MODY 3 or methyltyrosis diabetes mode 3. And it's not only him, it's also his father, because this specific form of diabetes, it can present with early retinopathy. So what's the implication? So what? Well, this child was on insulin and he wasn't responding. So we switched him to sulfonylurea, and with a small glycoside dose, you can see his A1C dropped nicely. And I have to say at that time, this was one of the earliest MODY in pediatric age group, and that's why it's got published easily. So the MODY, as I said, we had a complete lecture on MODY, but just to revise you, or just to remind you that it's an autosomal dominant form of diabetes, usually occur in the first 20 or 25 years of age, and typically they have non-ketotic hyperglycemia. Sporadic cases can occur. Obesity does not exclude MODY because obesity on the rise anyway, and it is a heterogeneous condition. There are now 14 MODY subtypes, and it's very important to recognize this type of diabetes because the management can be different. You can see here, sometimes you don't really need to treat patients at all, particularly with MODY 2. MODY 1 and MODY 3, they respond better to sulfonylurea than insulin. So it's very important to make the diagnosis of this one. So while we're talking about monogenic diabetes, the other form of monogenic diabetes is neonatal diabetes mellitus, which is my area of interest. And this is the diabetes presenting in the first 6 months of age. It's usually congenital diabetes, can be isolated or part of other extrapancreatic feature forming a specific syndrome, can be transient or permanent. But the majority of the transient, they can relapse later on in life around the teenager group. It's a pure genetic condition. There are more than 20 genes identified, or mutation in more than 20 genes identified in almost more than 90% of cases. And the reason why I would like you to know about this is because it is more common in Arab. The presentation is similar to type 1. Sometimes they can be just completely asymptomatic, incidental finding, and a child admitted to the hospital for any reason, or they can present with vomiting, diarrhea, poor feeling, and failure to thrive, or they can succumb into florid diabetic ketoacidosis. And this is data we collected recently, just showing you that the incidence of worldwide neonatal diabetes, and you can see here, Northwest Saudi Arabia has the commonest or the highest rate, followed by Qatar, Abu Dhabi, Oman, and the rates here is probably 5 or 6 times the highest rate reported in Europe and North America. So this is something we really need to be aware of. Now, let me finish with this young man who had beta thalassemia major. It's been under regular transfusion. He received desferoxamine, and he has clinically me at the age of 19. I met him when he was just under 18 years of age, and you can see here he's got polyuria, polydipsia, his glucose was high, hemoglobin A1C is high, and he also was prepubertal and with a number of endocrinopathies. And the most interesting finding was his serum ferritin was high, and that what caused his diabetes. So he's got a deposition of ferritin in his pancreas leading to diabetes. So thalassemia-related diabetes is very unusual form of diabetes, usually happen in long-standing patients with thalassemia needing blood transfusion. Usually people say this after 10 years. I don't think there's any evidence in the literature to suggest that, but this is the general feeling is the patients will have just mild glucosuria. They don't get DKA and they have low rate of complications. And as I said, the mechanisms, either iron deposition in the pancreas, chronic liver disease as part of the thalassemia, and some patients have genetic predisposition to develop this type of diabetes. Most patients need high insulin, but the good news is they rarely develop DKA. It's not common. Only one patient in our cohort who collected a long time ago. So in summary, most patients with diabetes have type 1. Around 50% present with DKA, some of them higher. All need insulin. When you talk about type 1 diabetes, insulin, there is nothing really you can do for them. The incidence of type 1 in Saudi Arabia is among the highest, and in Medina in particular is among the highest in the world. Other forms of diabetes, such as type 2, monogenic secondary diabetes, can present in children. And my advice, if you're not really sure of which type of insulin or which type of diabetes you are dealing with, better to give insulin and send the child to the hospital. And with this, I'd like to thank you. And I hope next time we have more time allocated for pediatric diabetes in this conference. Thank you very much.
Thank you, Dr. Abdelhadi, for this informative lecture. Now we'll move to diabetes in pregnancy with Dr. Iman Al-Fadli. She is professor of medicine and consultant of internal medicine and endocrinology in Taiwan University.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Arish, for this nice introduction, and thanks also for inviting me to give this talk. So my talk will be about diabetes and pregnancy. I will concentrate in the management of gestational diabetes. Management.
Sorry for this technical mistake. Now we'll move to the next speaker, Dr. Umar Abdelal. He is endocrinology consultant and head of endocrinology section, medical director in military hospital in Medina.
السلام عليكم. ترى أنا ما حاب أتكلم عن البريجنانسي. ترى إيمان أنا هتكلم عن رمضان. كل عام وأنتم بخير مقدما. Okay, so I've been asked. First of all, thank you, Dr. Arish, for this invitation, and it's my pleasure to give a talk about diabetes management in Ramadan. This one is not working. Anyway, each of us have his own memory in Ramadan. We are coming from different backgrounds, Saudi Arabia and from other Islamic country. But in Medina, what we remember Haram, remember الإفطار in الحرم in Quba, and الأشياء الخاصة بالمدينة المنورة. This is my general outline about this presentation, introduction, expected complication, recent guidelines, medication modification, and conclusion. بسم الله الرحمن الرحيم. شهر رمضان الذي ينزل فيه القرآن الآية. طبعا we're not the only people who fast. Other religious they have also fasting, but as always Muslim always unique. We fast for 29 to 30 days. In Jewish they have a different scale and of fasting. They fast maybe 1 to 2 days. Hindus also and Christianity also they have, but we are unique. We are fasting 29 to 30 days. The big question, how many Muslims in the world? The number of Muslims, mashallah, increasing, 1.6 in 2010. This number is expected to go to 2030 to 2.2 billion. And as you can see in this map, the majority of the expansion of Muslims will be in the MENA region and in the South Asia region. So, and the estimated prevalence of diabetes among Muslims is about 7%. We are talking about 55 million Muslims with diabetes. And most of them are type 2 diabetic patient, and maybe 40% are type 1 diabetic patient. Let me ask everybody here who are dealing with diabetic patient, what is the reaction when you ask your patient, are you going to fast, or you tell him that are you going to fast or not, or he will ask you the question. The thing that we notice, and most of you who are dealing with diabetic patient, is refusal. So the first thing they will say, no, we are going to fast. 99.99% they will say no. And the other, what I call them the ignorance patient, and those are the most dangerous patient, because they will they said, okay, doctor, we'll follow your advice not to fast, but they will do the opposite. And most of them, they will do this. I noticed some old patients, they will meet you with anger. أنت مسلم كيف تقول لي لا تصوم. This is some time, and some you can feel it in their face. They are very angry not to tell when you tell them. طبعا most of them when you deal with them they have the guilt feeling يعني فنحن نقول لهم كان مريضا وسافر فعدة من أيام أخرى, and they are convinced but they feel unsafe or not happy. So what are the challenges with fasting Ramadan? A couple of challenges. We fast according to Hijri calendar. This means that the fasting time is variable from time to time, different season. Sometimes we fast in winter, a short time of fasting. Sometimes we fast in summer, which is longer. We have everybody or all Muslim country have local social habits. In Ramadan, also we are reading Quran. We are praying Taraweeh, Tahajjud prayer, performing Umrah also, and everybody like to perform Umrah in Ramadan, and they prefer to do it while they are fasting. Altered sleeping pattern, this is a very, very important thing, you know, and it's common among all of us, not any, we don't sleep well in Ramadan, and also change in eating pattern. This is how normal people have. We eat normal feeding, breakfast, lunch, and dinner. But in Ramadan, unfortunately, we fast, and then هذه اللخبطة الشخبطة هذه اللي بتصير هي سبب المشاكل. Not only for diabetic patient, for even us as a regular patient. يعني after iftar, blood sugar will go, and then طبعا يلا بعد التراويح ايش باقي من الفطور؟ شراب التوت السمبوسك اديله ادي، بعدين والله اختك فيها جات في الليل جابت حلا اديله ادي، بعدين السحور وهلم يعني. And diabetic patients, they are living with us, so they will have this same pattern of so this is a blood glucose profile for normal patient. We tend to have blood sugar in the lower side before iftar, and then after iftar, routinely blood glucose will go. But in diabetic patient, they have a different, the revenge of the increased blood sugar after iftar is more significant, and before iftar, they are prone to have hypoglycemia. So this would make our life difficult when we are managing diabetic patient. Not only that, also the activity during Ramadan, as we know, we sleep at night and then we have our activity. But in the Ramadan, this sequence is interrupted. We sleep and wake up, and sleep and wake up, and also it's have its effect on diabetic patient. What are the risks associated with fasting diabetic patient? We have type 1, they are more prone to diabetic ketoacidosis, hypoglycemia, hyperglycemia, and dehydration. Okay, what about the epidemiology of type 1 diabetes? Unfortunately, until 2001, before that time, we didn't have any decent studying diabetes during Ramadan. But when EBDR study, and then alhamdulillah, we start to have more study, and I can convince you that we still need more study. This is regarding type 1. Type 2 diabetes, we have different study. All started, just imagine, we don't have, before 2001, we don't have any background, what's going on with the diabetic patient. And now for type 2, we have a lot of study, which helped us actually. Let me focus on the first study, and still up to now, it's a more extensive study. They studied about 13,000 patients. Most of them were type 2 diabetic patients, done in different countries in the MENA region, Algeria, Bangladesh, up to Turkey. So what they found that 79% of Muslim diabetes fast for at least 15 days, where in 80% in type 2 diabetic patient and 50% or 40% type 1 diabetic patient. Also, it was noticed that there is a risk of hypoglycemia was 7-fold increase in type 2 diabetic patient and about 3-fold or 5-fold in type 1 diabetic patient. And they noticed that severe hypoglycemia is more frequent in patients did not adjust the doses, timing of their diabetic medication, and significant, or those who have significant change in their lifestyle. Also, the risk of hyperglycemia was 5-fold in type 2 and surprisingly 3-fold in type 1. And for the diabetic ketoacidosis was more common in patients who were pre-Ramadan poorly controlled, or they were having excessive reduction in insulin doses. So steps towards safe Ramadan, fasting Ramadan. This is the last guideline done by Diabetes and Ramadan group. It is a practical guideline and published in 2021. And it's also under the vision of IDF. The people who participated in this study were among different Muslim countries, and I can tell you it's a very good study because it is very extensive. It's about 330 pages, and they include all the things that can be related in relation to diabetes and Ramadan. So the two-step towards safe fasting, pre-Ramadan assessment, which is very important. This will help us in risk assessment and risk stratification. And it should include pre-Ramadan education about self-monitoring, fluid and meal planning, physical activity, breaking, when to break the fast and medication adjustment, and then the diabetic management during Ramadan. Pre-Ramadan assessment and education. I think this is very important. We have to focus on this, and we notice in our hospital, and I'm sure that most of you notice that the more you educate your patient before Ramadan, the more the journey in Ramadan will be more easy. And in this, we should focus on detailed medical history, aspects of diabetes and ability of self-manage, presence of comorbidity, and the individual prior experience of the patient for last time when he fast Ramadan, ability of self-manage diabetes. And at the end of this assessment, you can stratify, quantify if your patient, whether is he a low risk, moderate risk, or high risk. And then you can guide him about the self-monitoring blood glucose. And the most important thing, we educate our patient when to break their fast, which is when blood glucose less than 70, or when blood glucose more than 300, or if the patient felt symptom of hypo or hyperglycemia. It's to make this assessment, it's very, all the information in this slide is very important because Ramadan-related factors like length of fasting, seasonal fasting, weather, geographic location, social changes, and past experience, it also should be included in this assessment. Diabetes-related factor, for example, type of diabetes, type 1 more difficult than type 2, duration of diabetes, diabetes complication, anti-diabetic therapies, previous control, and the other. And I think concern to the patient is himself, individualized concern, like the age, gender, occupation, and pregnancy, and all this. So it's not easy, it's a complex thing, but you should put all this in consideration when you deal with the diabetic patient who want to fast. And they propose like a score. So you at the end of this score, you can qualify your patient. Is he a low risk, moderate risk, or high risk? And it's very extensive score. I cannot go through it, but it's very first time to have like this score, and really it's helpful. But if you apply it to all your diabetic patients, most of them they will not fast during Ramadan because the score is very extensive. So after you score your patient, high risk level should not fast. The moderate risk advised not to fast. The low risk level should be able to fast. What about diabetes and Ramadan medical religious perspective? So what they did, this study that was discussed with the Dar Ifta al-Masri. And what you are going to see here is related to Dar Ifta al-Masri. It's not mandatory for everybody, but this is a thing that they did in this study. So medical and religious risk score recommendation. So if you have a patient who is a low risk, medically, fasting is probably safe, but fasting, they consider it as obligatory. يعني إذا جاك مريض في السكور حقه ده, what they propose إنه إذا كان low risk, يعني جا سألك يا دكتور هل يجوز لي أفطر؟ تقول له لا, you have to fast according to, but giving the fact always there is a safety, patient safety, and patient unable to fast if he have another issue. So it's not strict, but also can apply, you can manipulate with it. A moderate risk, fasting safety is uncertain. So here, as a religious recommendation, fasting is preferred, but patient may choose not to fast. For those high-risk patient, fasting is probably unsafe, but advised against fasting. So this is a patient, you tell him religious-wise, we recommend not to fast. So the other aspect is Ramadan-focused structured diabetes education. It's very important, and as I mentioned, I think it's very helpful. This target our healthcare professional, which include diabetes care team, healthcare support system, people with diabetes, individual themselves or family working with the patient or living with the patient, and the general public. The key component of Ramadan focused education should include risk quantification, blood glucose monitoring, fluid and dietary advice, physical activity and exercise, medication adjustment, when to break and fast, and recognition of hypo and hyperglycemia. So this is, if you check all this and be sure that the patient had all the information, I think it will be a very good value. Another thing is the 7-point blood glucose monitoring. So you advise your patient when to check blood glucose. And as we know, before fatur, 2 hours after fatur, before sahur, 2 hours after sahur, and then the midday and the mid-afternoon, or if the patient at any point felt hypo or hyperglycemia symptom. Is the education is effective? Yes, a lot of studies that showed that. One of them is called READ program, concluded that it's very effective. Another study also concluded that this studies, the education program have a lot of benefit. And recent meta-analysis published in 2022 also that showed that focused education led to decrease in A1C and increase also showed increase in triglyceride and weight during Ramadan, but with a better A1C and LDL improvement. So last 2 slides, modification in oral medication, metformin daily dose always remain the same, unchanged. Other oral medication, except the sulfonylurea, we have to adjust it. Acarbose, TZDs, GLP-1, DPP-4, no those changes. Sulfonylurea, if the patient, we recommend the short-acting sulfonylurea like gliclazide and glimepiride. Should avoid glibenclamide. If the patient is taking 1 tablet once a day, he should take it at iftar. And if the patient was well controlled during this, you can decrease the dose. If the patient is taking twice a day, iftar dose remain unchanged. Sahur dose may be decreased if the blood glucose on the lower side. Last point about SGL2 inhibitor. No dose modification, but should be taken with iftar, and the patient should be advised to take extra fluid ingested during non-fasting period. So, and should not be used in a elderly patient with the renal impairment and hypotensive individual. Insulin dose. For those who are in insulin pump, we routinely decrease the basal rate after iftar. and decrease it before iftar. So before iftar, we decrease it by 20 to 40%, and we increase it after a few hours by 10 to 30%. And bolus doses should remain the same. In patients who are taking basal insulin, basal bolus regimen, so basal insulin should be decreased by 30 to 40. And to be taken at iftar time. Rapid analog insulin dose at sahur to be reduced by 30 to 50%. Pre-lunch dose to be skipped, and the dose around iftar to be adjusted according to the reading after iftar. The basal bolus with the conventional insulin, MBH, and regular MBH, which should be shift all our patients to basal bolus. But if they have to take it, if the patient is using MBH, the usual pre-Ramadan morning dose to be taken at iftar, and the 50% of pre-Ramadan dose to be taken at sahur. And the regular insulin dose, evening dose, remain unchanged, and sahur dose also to be decreased by 50% at sahur time. A pre-mix analog, we don't recommend it, but morning dose should be shifted to iftar time, and we should decrease the evening dose by 50%. What about pregnancy when fasting during Ramadan? So many pregnant women with pre-existing diabetes or GDM are considered a high-risk group. So this is very important that whenever you are dealing with the pregnant lady, you should recommend that this is a high-risk group. Pregnant women must understand that regardless of their fasting status, they need sustained standard blood glucose target during pregnancy, fasting between 70 to 95, and post-meal less than 120. And pregnant women must understand that during pregnancy, they should break their fast if any of the following occur: blood glucose less than 70, or feeling unwell, or reduce fetal movement. Okay, we finished from the scientific side. Let's go to the most favorite time. I'll give you a clue about Ramadan in Medina. We have our own dessert, so this also more pronounced in Ramadan time. In Medina also, I don't know, for one reason or another, sport activity increase for football and for fera. طبعا التمر والهذا يطلع. البيكري ما شاء الله يزيد في الفتوت والشريك والاشياء الثانيه الحلوه دي. طبعا في شيء ما يطلع الا في رمضان اللي هو السوبيا اللي اعرفها، والفيمتو برضه ما يطلع الا في رمضان، وفي تون، وفي ناس يشجعوا هذا ويشجعوا هذا. انا من مشجعين الفيمتو. الكثير تطلع في رمضان البليله في الشوارع، ما ادري ليش بس في رمضان تطلع، ما اعرف. طبعا اللبس المديني المميز هذا يطلع في آخر أيام في رمضان، تبدأ تشوف الأشياء الحلوة دي. Conclusion, global Muslim population is increasing. Most of the diabetic patients will fast Ramadan, even if they are advised not to. Risk associated with Ramadan fasting, including hypoglycemia, hyperglycemia, dehydration. Risk assessment should be done for each diabetic patient. Pre-Ramadan education is very helpful. Ramadan focus structure diabetes education should be widely used. Knowledge about medication adjustment is essential. Patients should be do frequent blood glucose monitoring, know when to break the fast, and first generation sulfonylurea and premixed insulin should be avoided if possible. Thank you so much.
Thank you, Dr. Omar, for this nice presentation. So I'll start my presentation. So this is overview of my presentation, definition of gestational diabetes, how to screen and how to diagnose gestational diabetes, and then finally how to manage gestational diabetes. So gestational diabetes is traditionally described any abnormal glucose tolerance that is first recognized during pregnancy. But this definition is not correct 100% because we know that many patients with type 2 diabetes, you just discover them during pregnancy. So a more accurate description of gestational diabetes is hyperglycemia diagnosed at the second or third trimester of pregnancy. So what happened to the insulin sensitivity during pregnancy? I think this one is not good. لأنه هذا كويس ما في صدى حاسة كأنه في صدى. What happened to insulin resistance during pregnancy? First, sorry. So during the early pregnancy, the insulin resistance will improve or insulin sensitivity will improve. And at usually at the second and third trimester, the insulin resistance starts to increase gradually. And this is due to the secretion of the placental hormone that counter the action of insulin. So it increases gradually and it reaches the peak at the 36 week of pregnancy. After 36 weeks of pregnancy, it can plateau or reduce a little bit. So I'll go with this case, the 30-year-old Saudi pregnant woman. She is gravida 4 bar 3, gestational age is 12 weeks, presented to the antenatal clinic for her first visit. She has no history of diabetes, hypertension, and no history of a previous GDM. She has no obstetric history. Her mother has type 2 diabetes, and in physical examination, her weight is 60 and her BMI is 28. So only her risk factor for gestational diabetes is being overweight and family history of diabetes. So would you recommend for this patient to screen her for hyperglycemia in pregnancy? And the answer, yes, we should screen all pregnant ladies for undiagnosed type 2, or sometimes can be type 1 or even MODY. So please, any patient, pregnant lady at the first trimester, try to exclude undiagnosed diabetes. This is a study we did it 2015, and we found that almost 10 patients of Saudi women, they have undiagnosed type 2 diabetes, and we discovered it only during pregnancy. So how would you screen this patient at the first trimester? We do fasting or random or hemoglobin A1C, or what we call glucose challenge test or oral glucose tolerance test. And we can do the first 3. So if the patient come to me in the clinic fasting, I will order fasting, glucose, and A1C. If she is non-fasting, I will request random blood glucose and hemoglobin A1C. And this is the cutoff level. So it is the like in non-pregnancy state. So if the fasting is 126 or random 200 and A1C 6.5 and above, this is diagnosed over diabetes in pregnancy, or recognized diabetes in pregnancy. Usually it is type 2, but could be type 1 and could be also MODY. So gestational diabetes is usually diagnosed at the second or third trimester of pregnancy. If it is diagnosed, if you have a lady and having hyperglycemia in the first trimester, this is most likely not gestational, this is undiagnosed diabetes. So if the results are normal, would you screen her later for gestational diabetes? And the answer is yes. And this is the ADA recommendation. We have to do universal screening for all pregnant ladies to exclude the possibility of GDM. And unfortunately, this is not done. Many patients, many pregnant ladies, they don't go on to universal screening. And by this, we're missing lots of patients with gestational diabetes. We discover sometimes during delivery. So at what time would you screen her for gestational diabetes? 16 to 18, 24 to 28 weeks, 30 weeks, or at 34. And the recommendation is to rule out the gestational diabetes at 24 to 28 week of gestation. What is the best method to rule out gestational diabetes at this stage? It is by doing OGTT. So OGTT is vital to be done to all pregnant ladies, regardless of their risk factor. So OGTT, we have two approaches. We have the one-step approach, which is using 70 grams of oral glucose tolerance test. And there is another approach, is called two-step approach. So what do we mean by two-step approach? First, you will give the patient 50 grams glucose at non-fasting. So if the patient comes to you, she is not fasting, you can give her the 50 grams and assess her blood sugar after 1 hour. If it is reaching 140 and above, you should go and do the complete OGTT. So this is called two-step because you start to be with the 50, and then if it is positive, you go to the full OGTT. So this is the OGTT, the one-step approach and the two-step approach. This is the one-step approach. It's called International Association of Diabetes and Pregnancy Study Group. So you just do one step, you give the patient 75 grams of glucose, and you assess the blood glucose 1 hour fasting, then 1 hour and 2 hours. And if there is only one abnormal result, you can diagnose patient with the gestational diabetes. This is the two-step approach. After confirming high glucose after 50 grams, you go and do the 200 grams over 3 hours. So you check the fasting, 1 hour, 2 hour, 3 hour. And the two-step approach, they require 2 abnormal tests to diagnose gestational diabetes. So here in Medina, most of the time we are using the one-step approach. This is the same study in Medina. We looked at the prevalence of diabetes by using the 2 abnormal results and 1 abnormal result. So with using 2 abnormal results to diagnose gestational diabetes, the prevalence of gestational was 16.2. But when we use only 1 abnormal result to diagnose gestational diabetes, the prevalence of gestational will increase to 51. So very high. So it means every 2 pregnant ladies in Medina, one of them will be having gestational diabetes. So the increment was almost more than 3-fold. How about A1C for GDM diagnosis? Do we need to use A1C? A1C is not very sensitive in pregnant ladies because we know that there is increased red blood cell destruction during pregnancy. So it is not good tool to look for gestation because many obstetric colleagues, they will do only fasting and hemoglobin A1C at 24 to 28 weeks of gestation. And this is not very sensitive. So please don't depend on hemoglobin A1C to diagnose GDM. Depend on the OGTT. So how to treat the gestational diabetes? The lifestyle is the most important, and around 90% of the patients, you can treat them with a lifestyle, diet, exercise, and of course, those patients are instructed to do self-monitoring of blood glucose. And according to the self-monitoring, if they are controlled, you continue with the lifestyle. If not controlled, you have to start medical therapy. So diet, usually we ask the patient to reduce their food, but increase the frequency. So 3 small meals plus 3 small snacks. And this is to prevent the post-meal hyperglycemia. We know that the post-meal hyperglycemia usually affect the baby and cause macrosomia. So when the patient eat less amount in each meal, but increase the frequency, this will avoid the post-meal hyperglycemia and will improve or reduce the risk of macrosomia. Physical activity is very important, and the ADA, they recommend any pregnant lady to do mild to moderate exercise unless there is contraindication from pregnancy. So if patient cannot walk because of she has a risk of abortion, she can do any physical activity while seated or even sleeping. Any exercise, it will help. And usually I ask my patient to do just simple walking at home for 15 minutes, and it improve the blood glucose very well. Self-monitoring of blood glucose, this is vital thing. So if patient doesn't do it, there is no need to see this patient because you cannot know where is her blood sugar. So which one is recommended? Do we ask the patient to do the pre-meals or post-meal? Because for non-pregnant, usually ask them to check their blood glucose before meal. What about pregnant? Usually we ask them to check post meals. And why is that? As I mentioned, because of the post meal, which is increase of the glucose after meal, this glucose will be transferred to the babies, and this is what will cause the macrosomia and the other complication of pregnancy. So here in pregnant lady, usually we look for post meal blood glucose. So 1 hour or 2 hours, there is no difference. Some they said, no, it's better to do 1 hour. Some they said there is no difference. And maybe you leave it to the patient, which is more convenient to the patient. Or sometimes you look to their OGTT. If the abnormality in OGTT at 1 hour, you ask them to do 1 hour. If the abnormality at 2 hours, you ask them to check at 2 hours. And this is the glycemic target. We want the fasting below 95, 1 hour below 140, and 2 hours below 120. How about monitoring? We said A1C is not sensitive during pregnancy. How about the follow-up of A1C during pregnancy? Again, A1C also is not very good in to follow patient glycemic control during pregnancy, unless the patient to started with very high A1C. So if she is started with 7, 8, yes, you could follow. But if the patient from start, usually gestational diabetes, they have milder form of hyperglycemia. So if she started with a 6, maybe there is no point of following the A1C. And because of the kinetic changes of RBCs, maybe you could follow hemoglobin A1C in pregnancy every month, not like in the non-pregnancy state. We usually follow every 3 months. How about continuous glucose monitoring use in pregnancy? This is very good tool to follow the blood sugar, and it should be used in conjunction with self-monitoring of the blood glucose. This is a study we did it before in using continuous glucose monitoring system in pregnant ladies. We used before it is for 3 days. And as you can see, using only the continuous glucose monitoring for 3 days improve the average glucose significantly. Also, it decreased the variability of the blood glucose significantly. It decreased the hyperglycemia and hypoglycemia, but these two did not reach statistical significance. And I think this is most likely because we use it only for 3 days. So our conclusion that using continuous glucose monitoring system in patients with gestational diabetes is an educational and motivational. So as you know, patient diagnosed with gestational diabetes at 24, 28. They have to control their blood sugar very quickly. They have no information about glucose. This is the first time to have glucose, and they need to learn a lot. So using the continuous glucose monitoring will help them to achieve this target. So they will know how sleep affects their blood glucose, how exercise affects the blood glucose, how is the meal. So it is an educational tool for them. We know the time and range. We have yesterday the talk about time and range. And this is the time and range in diabetic patient, just to concentrate in the patient with gestational diabetes. So the target range in pregnant lady with diabetes, blood sugar should be from 36 to 140. And for type 1 diabetes, For type 1 diabetes, we need most time and range to be more than 70%. For type 2 and gestational diabetes is not very clear, but the proposed, they should be 90% of their blood glucose in the target. So if you start your patient in lifestyle modification and still their blood sugar control, you need to think of medical therapy. And the medical therapy, we have insulin, which is the gold standard, and we have the oral hypoglycemic agents, metformin and glyburide. Glyburide, which is glibenclamide. So all the societies agree that first line of therapy of gestational diabetes should be insulin. And oral agent can be used as alternative. NICE, which is a British guideline, they prefer to use metformin in patients with mild gestational diabetes because it has a low risk of neonatal hypoglycemia and weight gain. So if we compare insulin to oral agent, we know that insulin is invasive. Oral agent, no. The insulin regimen usually complex. The oral agents are easy to take. Patient compliance with the insulin will be suboptimal, but with the oral drugs will be better. Cost also is expensive for insulin, cheap for the oral agents. Weight gain and hypoglycemia are side effects of both insulin and glyburide. The efficacy is highest for insulin, less for glyburide, and least for the metformin. We have many studies that prove that the oral agent may be safe in the short term, but we don't know the long-term sequelae of using oral agents in pregnancy. So what is the ideal candidate when you think of giving oral agent to pregnant lady? For women who refuse to take insulin, or patient non-compliant, or if the access to insulin is limited, like if the patient is living in the desert, she cannot obtain insulin. And most important point, it has to be mild gestational diabetes. If it is very high blood sugar, please don't try oral agent, try immediately insulin. So if the fasting below 126 and random below 200, you could try oral. And also, if the gestational diabetes diagnosed late after 24 weeks of gestation, you could try. But if it is started early, please start immediately insulin. And also lower body mass index. If the patient obese, she will not respond to the oral agents. And singleton pregnancy. If a patient is having twins or triple, it's better to start insulin. So when metformin could be considered as first-line therapy, as I mentioned, it has to be mild diabetes, like fasting below 126. What is the dosing, how we can dose the metformin? Start usually by 500, whether it is rapid release or extended release. If no response, you can increase the dose until you reach the maximum dose of 2,500. If diabetes not controlled with the maximum metformin dose, you could add insulin to that. There is conflicting evidence that using metformin in pregnancy might lead to increase the risk of preterm birth. And also follow-up studies of children exposed to metformin lead to higher BMI at the age of 4 to 10 years. And why is that? It is not very known, but maybe because of the low birth weight. Usually babies who born with low birth weight, they can catch up quickly and they can have obesity in when they become like 10 years. When you think to use gluburide, if blood glucose target are not achieved with metformin, but the patient denied insulin, or if the patient cannot use insulin because of side effect, if he cannot use metformin because of GI intolerance, and she refused insulin, we should think of using gluburide. So gluburide should be considered inferior to both insulin and metformin. So the first drug, insulin, second metformin, and gluburide should be the third one. And this is because gluburide is associated with increased neonatal hypoglycemia and also macrosomia. Gluburide dosing in gestational diabetes, you start with by 2.5 to 5 milligram before breakfast. And if the blood sugar is still not controlled, you could add 5 at night, and then you increase the dose until you reach 20 milligram per day. If still blood glucose is not controlled, you could add insulin to that. When insulin should be considered as first-line therapy, most of the time insulin is the first-line therapy, especially if the blood glucose is high, above 126. If the blood glucose is mildly increased, but the patient has already complication from hyperglycemia like macrosomia or polyhydramnios, you have to start insulin to reduce the risk from those. So insulin regimen, type, and timing of insulin should be chosen according to the specific blood glucose elevation. So in this patient, she is checking her blood sugar fasting and 1 hour post meal. So fasting is 105, so it is high. We said we want it below 95. 1 hour, all okay, because we said up to 140 is acceptable. So the only abnormality of this lady, she is having fasting hyperglycemia. So how are we gonna manage her? You just give her a small dose of basal insulin at bedtime to correct this fasting hyperglycemia. For this lady, she is having a problem with the fasting as well as post-lunch. So how are you gonna treat her? It's just you give her basal insulin to correct the fasting hyperglycemia, and you give her rapid-acting insulin or bolus of insulin before lunch. And usually we start by 4 if the blood glucose is not very high. For this patient, she has all or her reading are high, fasting and all post-meal. So how are you gonna treat her? We give her 1 basal insulin and we give her boluses of insulin before each meal. But if you think this 4 unit will not touch the patient, you could calculate the insulin dose according to the weight. So in the first trimester, you give 0.7 unit per kg, second trimester 0.8, and third trimester 0.9. And then the total daily dose, you will divide it into 50-50. 50 will be as a basal, and 50 will be as a boluses. You will divide the 50% into 3 meals. And better for the pre-meal, it should be according to the carbohydrate intake. So 1 unit of insulin per 10 to 15 grams of carbohydrate. Which type of pre-insulin would you prefer? Is it regular insulin or rapid-acting insulin? It should be rapid-acting insulin, and this is why. Because when we eat food, usually within 4 hours, the food is absorbed. When we give the regular insulin will start to act after half an hour to 1 hour. So at this time, there will be hyperglycemia. And when the food is absorbed, there will be the peaking of the regular insulin at this point, and here patient can have hypoglycemia. So giving regular insulin in pregnant lady can have first hyperglycemia and late post-meal hypoglycemia. But giving the insulin analog, like Aspart and Lispro, is matching very well the time of food absorption. So will lead to less hyperglycemia and less post-meal hypoglycemia. So both Lispro and insulin are approved to be used in pregnancy. The glulizine is not yet approved. For basal insulin, which one do you prefer? Ditimer, glargine, NPH, or premix? Ditimer is approved and it is one of the FDA drug approved to be used in pregnancy. What about glargine? Yes, we are using glargine, although it is not FDA approved, but many studies prove its safety. And most of the time in our clinic, we are using glargine because it covers 24 hours and lead to better glycemic control than Ditimer. Usually we try to avoid MPH because of the peak after 4 hours to avoid hypoglycemia, and premix usually we avoid it. So this another case, 36-year-old female, gravida 3, para 2. She is gestational age 26 weeks, diagnosed with gestational diabetes for 2 weeks. She has tried diet modification and exercise to control her blood glucose level. Her average fasting was 105, so still high, and average 2-hour postprandial was 140. She is absolutely terrified of needles. So what medication should be considered to manage her blood glucose? Gluburide, metformin, pioglitazone, or insulin? And the answer will be the metformin. If the patient cannot use insulin, the second choice will be metformin. This is another case, 30-year-old female diagnosed with gestational diabetes. 1 week, she is 25 weeks of gestation. She tried dietary therapy and exercise over the last week. Her average fasting still high 110, and average 2-hour post-meal still high 160. She tried metformin in the past to help reducing her weight, but did not tolerate it because of GI upset. She is refusing to take insulin. So which medication should be used? Again, we can use gluburide for this patient. So just to conclude, maintaining adequate blood glucose level in gestational diabetes reduce morbidity for both mother and child. All pregnant women should be screened for gestational diabetes. At the first antenatal visit, test for undiagnosed diabetes using standard diagnostic criteria. If the above measures are normal, you have to screen your patient for gestational diabetes between 24 to 28 weeks of gestation using oral glucose tolerance test. The primary treatment of GDM is lifestyle modification, which include diet and exercise. And you have to tell your patient to check their blood glucose, fasting, and post-meal. So insulin analog are associated with less risk of hypoglycemia and may provide better glycemic control than human insulin. And Lispro and Ditimer and Aspart are approved to be used in pregnancy. Glargine is not approved, but many studies indicating its safety and good effectiveness. Oral hypoglycemic agent, both metformin and gluburide, can be used for management of gestational diabetes. However, metformin is the preferred over gluburide. The use of metformin and gluburide by breastfeeding mothers, when necessary, appear to be safe. So if the pregnant lady after delivery want to use oral agent, we can use both metformin and gluburide. Thank you so much.
Thank you, Dr. Iman, for this informative and interesting lecture. Now we'll move to the next topic with the diabetes and nephrology with Dr. Shuaib Qusji, nephrology consultant in Prince Mohammed bin Abdulaziz Hospital at Medina.
Yeah, Assalamu alaikum and good afternoon. It was supposed to be a good morning, but it's now noon. I guess we are running late and supposed to be a diabetes conference, but I think most of us are low on sugar right now. So I'll try my best to make it concise, inshallah, and go through the main points. Basically, the talk should be covering epidemiology of diabetic kidney disease, mechanisms of CKD and diabetes, how to assess current guidelines and the recent advances in diabetic CKD, and the need to transform diabetes care. And I'll go through this quickly in epidemiology because we've heard about this over the last 2 days. The leading cause of ESRD worldwide is diabetes. More than 50% of the cases who are on dialysis have lost their kidney because of diabetes. Worldwide, if you look, in the last year, there are about more than 500 million cases, 537 million cases with diabetes. Most of them were type 2 diabetes, about 95% of them, and 5% were type 1 diabetics. 40% of type 2 diabetics will end up with ESRD, with diabetic kidney disease, and 1/3 of the type 1 diabetics. So basically, about half, if you see, half of the chronic kidney disease worldwide is directly from diabetes. And the important point is, unfortunately, most of them will end up dying because of heart failure or atherosclerotic disease or cardiovascular complications. 10% of those who have CKD will eventually progress to the point that they fail with their kidneys and they need dialysis or transplant. And this is a vicious cycle. Diabetes worsens kidney disease and cardiovascular disease. People who have kidney disease have bad cardiovascular disease, and people who have cardiovascular disease have more progression of their kidney disease. So it's just like a vicious cycle which worsens one to the other. What are the mechanisms? 3 main mechanisms we have in diabetes. The old thinking is diabetes causes high blood sugar, and high blood sugar is responsible for all the damage in diabetic kidney. That is the old thought. And definitely metabolic factors are there, but you have hemodynamic factors, and you have a lot more information we have now on inflammatory and fibrotic factors. This is the classical mechanism of injury, the glomerular hyperfiltration model, where we have been told that this is, if you see at the level of the glomerulus, this is the afferent arteriole, and this is the efferent arteriole. Blood comes in through here, the glomerulus, and comes out from here. In diabetes, this becomes dilated, and this becomes constricted. So you have a lot of blood going in and very little blood coming out, causing glomerular hyperfiltration and eventual downstream albuminuria. However, we now know that it's much more than that. We have about 8 different pathways for diabetic nephropathy. Hyperglycemia is only one of them. So you have 7 or 8 things which are going on at the same time, causing progressive worsening of the kidney disease. So what do we do about it? Well, we need to screen. Why do we need to screen? Because kidney involvement in diabetes is asymptomatic. You don't get pain, you don't get hematuria, you don't get dysuria, you don't get any urinary symptoms. And it takes a long time before this comes up, so it's asymptomatic. And we'll talk about how to diagnose and how to confirm and how to prevent complications from our treatment. And this is the importance of this little graph, if you see here. From the time of onset of diabetes, if you see, it might take up to 5 years before the patient develops microalbuminuria, which is the first sign of kidney damage. So he could be walking around or she could be walking around not knowing, and this could happen anytime, this time. And then once that happens, this goes upwards. And then 10 years onward, there's a steep slope where the proteinuria progresses from micro to macro to overt proteinuria. At this time, this is the only evidence that the kidney is being affected. Your GFR, which is on the blue graph, remains normal. In fact, the GFR might go higher, so the creatinine on the left might be lower. And falsely, we think that the kidneys are doing a good job because the creatinine is only 60. But actually, the kidney is going through a hyperfiltration stage where, because of the direct effect of diabetes, the GFR is actually high and the creatinine is low. The point of intersection comes here, where now the GFR is around 60s and the patient has about 2-3 grams of proteinuria. This is where I get most of my consultations, this cross point, when the patient is having more proteinuria and the GFR is falling. That's actually too late for me to intervene because at this time, this is a downward fall. So our goal is to maintain the GFR around here at this flat line, and to maintain the microalbuminuria at this flat line. That is the goal, and that's why we need to screen early and intervene early so we can do a primary prevention. Most of the times we are talking about secondary or tertiary prevention by the times the patients come to us. So how to screen, when to screen? Type 1 diabetics every year, beginning from 5 years after diagnosis. Type 2 every year. As soon as you diagnose a type 2 diabetic, start the screening. Simple method to screen. It's not complicated. Just do a simple spot urine albumin to creatinine ratio available in most of the basic labs today, and do a simple blood test to look at the creatinine, and the lab will tell you what is the GFR for the patient. So albumin creatinine ratio is not actually the dipstick which you do normally to look for proteinuria, because that dipstick shows you 1 plus 2 plus 3 plus glucose or protein. This is actually a ratio between albumin and creatinine, measured usually with milligrams and grams. In SI units which we use, it will come as milligram to millimole. So what we define that the patient is having CKD, if you have persistent urine ACR more than 30 or a GFR less than 60, okay, you need only one, you don't need both. And you may have both, or you may have some other evidence of kidney damage like on the ultrasound, the kidneys are not looking normal, you might have shrunken kidneys, that might suggest some other disorder. Once we have this evidence, you need to confirm this. One value done for one spot urine test is not accepted as a diagnosis. You need to have at least 2 abnormal values. You have to repeat it 3 months apart. Sometimes the GFR can go up and down, so the creatinine might not be very accurate. In those situations, nowadays we can use cystatin C, which is available in some labs, not all labs, but most of the labs will use just simple creatinine. And once you confirm, once you have 2 abnormal values, that is your confirmation. You need to initiate evidence-based treatments. Everything in diabetes, alhamdulillah, now is evidence-based. It's not conjecture, it's not experience-based. Experience is a big role player in managing, but there is evidence now to back up most of the things which we do. And I'm sure you've seen all of these in the last 2 days, many standards of care now published, consensus guidelines published between different societies. KDIGO has published outcomes analysis, and we have a lot of referrals to go back on to study and understand how to approach these diseases. And the goal when we are treating diabetic CKD is to prevent going into this red zone. You see, this is the prognosis of CKD once you diagnose the people about how bad are the kidneys going to do. So we start with a patient who has normal GFR. As we go downwards, GFR 30 or below, the risk of further progression, need for dialysis and complications goes higher. And on the x-axis, you have the albuminuria. Patients who may have A1, mild microalbuminuria or moderately increased, are relatively okay. They're in the yellow zone. Once you have high proteinuria, that is again a very high risk for progression of CKD. And that's where the recommendations nowadays come for patients or for physicians and practitioners who are treating diabetics, when to screen only and treat yourself, and when you need to take the help of a specialist to refer. And if you see, most of the cases below GFR 30, you should refer. Even though you are comfortable and things are going smoothly, you need to get your specialist involved at that time. Your recommendation is about even referring at earlier stages of GFR if the proteinuria is high, should refer. Get a second opinion, just get a backup to make sure that things are exactly as you are planning and there's nothing to be added or changed from the perspective of the subspecialist. And what is the evidence-based care? We talk a lot about this, comprehensive, a word which is used frequently in our management, and indeed it is comprehensive. It is not like, oh, you have diabetes, so the first thing comes to the mind, fix the blood sugar. Okay. The comprehensive care in diabetes and diabetic CKD is actually involving these things which should be taken care of, which means as a practitioner, as a nurse practitioner, as a physician, family practitioner, once we get a patient of diabetes, the control of blood sugar is equally important as control of smoking, nutrition, exercise. So the recommendations are all patients should be taught and be focused saying, it's not like, okay, you have diabetes, just control the blood sugar, take this metformin, take this sitagliptin and finish. Okay, time should be spent to look at these 6 factors equally. Then most of the patients now will need to be on RAS inhibitors, ACE and ARBs, and SGLT2. We need to change our pattern of thinking now. Diabetic CKD with microalbuminuria for the last 25, 30 years, we have been just saying ACE and ARBs, ACE and ARBs. Now it is ACE and ARBs plus SGLT2. And then some of the patients relevant to the cardiovascular status would be on antiplatelet therapies. So that's comprehensive study. Diabetes dietary management, only 2 slides on specific for CKD management. They should be on a low protein diet, 0.8 gram per kilogram of protein with a balanced animal and plant proteins. And they should all have a low sodium diet, irrespective of whether they have hypertension or not. Because hypertension here, we know we have high quality evidence about hypertension causing improvement in blood pressure, and it does affect and decreases cardiovascular disease, stroke, and progression of CKD. Glycemic monitoring, it's no longer keep the goal hemoglobin A1C less than 7. That is old. It's not like hemoglobin A1C less than 7 for all. It's really now individualized. Okay, look at the patient and decide. So you can have a goal of less than 6.5. You can have a goal of less than 8 for the patient. And these are the factors which you will look at when you decide that. And most important, look at the comorbidities. Okay, patient is having fewer comorbidities, younger patient, longer lifespan. Be tight on the hemoglobin A1C control. On the other hand, the patient's IC, multiple comorbidities, limited life expectancy. In those cases, really, we don't need to go for the hemoglobin 6.5 or 7. Even up to 8 would be great, not a problem. And so we do the lifestyle. And after the lifestyle, this is the most important part. Okay, they all should be on first-line drug therapy with SGLT2 and metformin if the GFR is more than 30. They all should be on an ACE and ARB, and they all should be on a moderately high statin. RAS inhibitors, ACE and ARBs are still the cornerstone of diabetic CKD management. If things don't get controlled with this, then now we can also use GLP-RA agonists and the non-steroidal mineralocorticoid agonists. So ACE and ARBs remain the cornerstone, and not because they control the blood pressure. Their protective effect on the kidneys is independent of the blood pressure. And that is why, if you see, this is placebo, this is irbesartan 150, and this is irbesartan 300. Higher the dose of the ARBs or the ACE, better is the kidney protection. That is why we use the word maximize ACE and ARBs. We don't say stop at the blood pressure if the blood pressure is 130. We try to maximize the maximum tolerated dose to achieve maximum renal protection. SGLT2 inhibitors are now we can call them the statins of 21st century. Okay. Why are they called the statins of the 21st century? Because if you remember the people my age who were introduced to statins in 1990s and 1980s, they were revolutionary. Drugs which made a major impact on the cardiovascular disease, on the neurovascular disease. Okay. After that, it is the SGLT2 inhibitors who have made a major impact. And thousands of trials. Dr. Balavi earlier today mentioned a lot of trials on SGLT2 and GLP-1 agonists. And basically, there's a lot of data to support the use of SGLT2 inhibitors. They basically block the absorption of glucose in the proximal tubule, causing glycosuria and causing loss of uric acid, and multiple beneficial effects, improving blood glucose, body weight, blood pressure, uric acid, and decreasing the hyperfiltration. So we go back to this slide. SGLT2 will help and correct 6 out of the 8 pathogenic effects of diabetic nephropathy. It's not just controlling the blood sugars. So that's why they are so beneficial. This is a look at the timeline of the trials which have been going on. You see all of these boxes in pink. If you see, these are all trials of SGLT2 inhibitors. The trials and the boxes in orange are all GLP-1 agonists. So there is immense data, thousands and thousands of patients being studied, which have proven that these agents are beneficial. And this is just a snapshot of the trials. I'm not going to go into details of the trials for lack of time. 40 to 50% risk reduction for N composite endpoint, which means preventing the doubling of creatinine, the need for dialysis, or death. Now, they are good agents, but you need to be aware that there are certain contraindications. They do come with side effects, including the need for looking for diabetic ketoacidosis. The incidence is small, 0.1 to 0.3%, but there is a chance of euglycemic diabetic acidosis also. Fungal infections can happen because there is glycosuria. So if you have more sugar in the urine, you might get higher chances of genital infections, foot ulcers, and patients who are immunosuppressed. So that is why there is a lot of now practical provider training to get physicians and care providers comfortable with how to use these agents, because there's a lot of physician inertia to start these agents because of the fear of causing complications. And we need to educate the patients also. There is a sick day protocols. They need to stop their medications if they are sick and going to get volume depleted. Preoperatively, if there is a risk of AKI, they should stop it for 3-4 days. And this is the graph I would like to get your attention to. This is an average diabetic patient, which was taken up from the Credence trial, one of the largest trials for the canaclophysis. 63-year-old male, eGFR is around 55, 56, and he has proteinuria, classical diabetic CKD patient. And when you see here, when this guy, if you just give him the standard of care, he will lose his GFR by about 4 to 5 ml per year, and by about 10 years after diagnosis, which means when he reaches the age of 73, he probably will end up needing dialysis. You put the same patient on an SGLT2 inhibitors, now the fall in GFR declines from 4 to 5 ml per year to 2 ml per year. And now, by the time this patient may come in need of dialysis, he has lived up to the age of 88. And that's an immense benefit, which means you're looking at a 15 years of dialysis-free survival, which is great, which we haven't seen that, in any of the other agents. So it's really a big benefit, and that is why we all need to get comfortable with how to use these agents. And if you see metformin, we can use now up to the GFR up to the stage 3B, 30. GFR below 30, metformin is contraindicated. SGLT2, you can go on. You can go on up to eGFR 25 and eGFR even 20. So even later on, when you have patients who have advanced CKD and the GFR is low, even up to 20 to 25 ml per minute, you can initiate these agents and just monitor them. There is still a benefit. Dr. Balavi gave an excellent lecture earlier today morning. I'm not going to speak on that, but in addition to all the other effects, GLP also have renal benefits. And the last newer agent is finerenone. There's a lot of data now coming on this medication. This is actually not an anti-hyperglycemic agent like SGLT2 or GLP. It is a completely different agent. It blocks fibrosis inside the kidney. So there is a downstream blockage of inflammation, fibrosis, and oxidative stress by finerenone. And Fidelio was one of the largest trials, which was recently published, about 6,000 patients. And it does show that there is significant improvement in primary outcomes and secondary outcomes in patients who are on finerenone. So we will need to add that on in patients who still have uncontrolled albuminuria. So now these are two arrows. This is what we've been doing: glucose control, BP control, RAS inhibitors, lifestyle control. And this is now what we have: SGLT2, GLP-1, and finerenone, endothelin are coming in. And we need to now combine the traditional with the current to achieve the best care. So the drug pipeline for CKD is richer. We have a lot of choices. New interventions are available. The challenge is on us as healthcare providers. How do we use this now? Okay, everything is available. It's just up to us. And there are barriers to this. What are the barriers? Number one, low CKD awareness. Okay, among the patients, even among the providers, there's a data to show that not everyone is getting screened. There's data to show not everyone is getting put on the right agents. There is a high complexity of care, which makes people a little bit difficult to initiate agents. People go to cardiologists, nephrologists, internists, and the complexity of care causes problems. And there's also difficulties with the patient who may have difficulties to adhere to these complex regimens. And there is a low recognition and application of guidelines. Everyone knows the guidelines. When it comes to putting those in practice, the data shows that we don't do a good enough job. So the need is, you need to have a newer care models of transforming this care. You need to have multidisciplinary education, which we do. Okay. You need to harmonize clinical practice guidelines. MANE, ADA is making a guideline. EASD is making a guideline. ACC is making a guideline. KDIGO is making a guideline. How many guidelines do you refer? And so now what societies are doing is they are just putting all of this together. The societies are coming together and they are trying to kind of harmonizing the clinical guidelines. We need to have self-management programs and different care models and risk mitigation strategies, because all these agents we use, they have their own risks. So we need to be preventive in taking care of the complications. Last couple of slides, we should take the lead. Physicians need to take the lead to embrace guideline-directed therapy. And the leadership should do the multifaceted approach, which is what we are doing right now. The leadership should take the lead in educating in conferences like this, in public health approaches. And we need to develop educational resources for the patients and the staff so that everyone knows what is available and how it can be accessed and how it can be implemented. So last slide, the burden of CKD is immense, but CKD screening and diagnosis is very simple. And new agents are now available, which are going to preserve life, preserve the heart, and avoid the need for dialysis. And we need to shake off our inertia, adapt and implement this as soon as possible. And this will be beneficial for the patients. Jazakallah khair.
Thank you, Dr. Shuaib, for this informative session. Please, to all our speakers, if you can come to the stage for opening discussion. Dr. Bushra. Anyone have a question now?
Thank you, Dr. Shuaib. Was very informative lecture. My question, if you first see patient with diabetes GFR between 20 and 30, would you start SGLT2 inhibitor? This is the first question. The second question, do we have Feniron in Saudi Arabia? Do we have Feniron, the MR antagonist? Do we have it in Medina? So for the first question,
Fenirenol is not currently available right now, but it's going to be available soon. So that is an add-on agent which can be used once it's approved. It's FDA approved currently just in US. Saudi FDA, I think it is still under the process.
so do we need, I mean, can we use now like Aldactone until we have this agent?
Yes, yes.
So my first question, first present to me, at the first time, his GFR is between 20 to 30. Would you start SGLT2 inhibitor?
I think when the first time, if you see the GFR is 20 to 30, the best thing is to just refer to nephrology at that time. Because at that time, once the GFR goes below 30, the complications of the medications itself, whether it is an antihypertensive or antihyperglycemic or any other, cause barriers to making a proper plan. And so at that situation, I think before initiating anything new, especially SGLT2, it is better to refer to nephrology to review that case and see if that patient would be a candidate for SGLT2. Patients below the age of 30, usually the magnitude of benefit from SGLT2 will be lower, especially because their GFR is low and glycosuria was lower, and they are more prone to complications from volume depletion because they are already on a diuretic from cardiology. They might already be on other agents which can impair GFR.
Any more questions?
Assalamu alaikum. I'm Mayara Al-Harbi. I have a question for Dr. Suha. What is the best dietary modification for diabetic patients who at high risk for cardiovascular disease?
Okay. Dr. Abdul Hadi, if you can give answer for this question. Can you repeat, please, the question?
What is the dietary modification for diabetic patients who at high risk for cardiovascular disease?
I was given the microphone, but I think I'm the wrong person to answer this question. I mean, our diabetic children do not get to the stage of cardiovascular disease, so I don't know if any one of you can answer the question.
Yeah.
Maybe Omar.
This question for Dr. Suha.
Yeah, in general, diabetic patient, the cardiac disease, they should have low salt. This is what I can say. Low lipid, low, but there is no specific recipe for them, you know. But should be advised for any diabetic patient: low calorie, low lipid, low salt.
Yes, that's it. Great. Also, I can add something. There is no specific dietary advice for specific patient or any patient who have a complication. But every patient have individualized dietary advice. If patient have cardiovascular disease, so low lipid, low salt, low potassium level, like also in coronary. Chronic kidney disease with diabetes. Also, the patient must have low potassium and low protein diet. So, any more questions?
Assalamu alaikum. I'm Khulud Mutairi. I have a question for Dr. Iman. What's the role of using semaglutide injection in pregnant diabetic female?
So the only approved drugs to be used in pregnancy, insulin, metformin, glyburide. All other treatments are contraindicated. We don't have any safety data, especially for the new one, which is like GLP-1, like semaglutide and SGLT2. So if the patient, like some patient, they do present, some patient at childbearing age, they want to use semaglutide. So the first question I should ask, do you want to get pregnant? If they want to get pregnant, we shouldn't give them because it is contraindicated.
Assalamu alaikum. Ana Rosa Saadi. I have a question for Dr. Abdul Hadi. At what age is the liraglutide approved to be using in pediatric age group?
The current recommendation is 12 years and above.
Okay, now we'll move to a video about patient experience. It's a video about complicated patient with diabetes who's treated in diabetic clinic in National Guard.
السلام عليكم ورحمة الله وبركاته. السلام. كيف حالك أستاذ تهاني؟ اليوم حابين إنك تشاركنا تجربتك عملية اليوم هذا الجلسة. يومك.
طيب الحقيقة أنا اكتشفت السكر يعني بالصدفة وكنت بشعر بعطش بشكل ما عادي قدري ما أشرب ما أروى. ففي ذاك اليوم قررت إنه أنا أحلل السكر وفعلا تفاجأت بأنه كانت النتيجة 100 ملي جرام زبدة. وبعديها لجأت للطبيب كتب لي نوع من الحبوب واستعملتها كانت ميتفورمين ومعها دايمايرون واستمريت عليها بالنظام اللي حكى عليه الدكتور بس كانت النتائج دائما تكون 180 200 300 وهكذا. فبعد ان انتقلت الى المملكه العربيه السعوديه عملت تحويل من الحبوب الى افصل الاطباء يعني حقيقه بانه لازم اخذ انسولين رابيد واخذ انسولين لانتوز جلاجين. فاستمريت عليها مع ذلك كان بيكون فاستنج 180 بعد الفطور بيكون 300، بعد الغداء بيوصل 400 وشويه، وكنت مستمر على هذه الحال. فتقريبا مشيت لطبيب استشاري واوصاني بتغيير كل العلاجات، وبديت اخذ دائما كورونا 60 ملي جرام كاربوني، وبعد الفطور بكون عندي لحد الغداء بقيس. الاسبوع الاول كانت شويه عندي 60، بس بعد اسبوع اتفاجأت بقى ان السكر يكون فاصل 80، وبعد الغداء باخذ دائما زي 2 ملي جرام، بقيس بعدين 160 120 130 رينجينج يعني من 120 ل 180. استمريت بعد اسبوعين باخذ 60 ملي جرام دائما دول قبل الفطور بنص ساعه، ووقفت الخبز الابيض نهائيا، ووقفت الرز نهائيا، باكل خبز الشعير لانه محتاج للخبز، فقط خبز الشعير. بعد الفطور بقيس بلقاه 110 لحد 120 123 تحت راسي. بعد قبل الغداء باخذ دواء الجلوكوزين 10 ملي جرام واتغدى عادي، بقيس بعد ساعتين بوست برانديل بلقاه تقريبا 140 150 153 120. فالعشاء باكل دائما سلطه بويلد اكس بدون نشويات، بدون خبز، بدون اي شيء، بس سلطه. يعني كل النشويات والنية تكون دجاج. النشويات كلها بس غير خبز الشعير ما بستعمل شيء وايد، خبز الشعير وايد. طيب من متى مع 22 سنه؟ 22 سنه. ايوه. طيب ايش نوع السكر اللي تشخص فيه؟ النوع الاول ولا النوع الثاني؟ ايش كان النوع الثاني؟ النوع الابيض اللي بيستخدمه بالشهور. يعني تقريبا مشي سريع، مشي سريع تقريبا 3 كيلو مشي سريع، يعني ممكن اقضيها في نص ساعه. ماشي 3 كيلو ماشي، تزيد 5 دقائق في 4 نص ساعه. معانا بشرة الصباح اول ما استيقظ تقريبا 20، وبوقف وبقعد على عضلات الفخذين مع عضلات الساق أكثر من 20 إلى 30 مرة في اليوم الصراحة. ممتاز. طيب استاذ نعم، إذا حطنا الجروب بيصير خلال 3 شهور تحسن نسبة السكر بشكل ممتاز. والله هذا ممكن تعزيز الالتزام بمواعيد الوجبات، بمواعيد الدواء، بالرياضة وبالحمية. طيب كيف الالتزام بالحمية والرياضة والذي أكثر؟ والله أنا وجدت إنه حتى الأعراض اللي كنت بحسها في جسمي أول لما كانت النتائج تكون يعني عالية جدا في قراءة السكر، وجدت فرق كبير جدا. السحانة بالأرجل ضاعت، انتهت. يعني كانت معك حرارة الأرجل شديدة وعطش شديد مع الجوع، أحيانا تحس بأنك جوعان شديد لدرجة أنك ترجف. شكرا استاذ سبحان ما قصرت. يعطيك العافيه. الصحه والعافيه.
السلام عليكم. Now for Dr. Turki to start الحفل الختامي إن شاء الله.
قولا ممن دعا إلى صالحا وقال إنني من المسلمين ولا تستوي الحسنة ولا السيئة ادفع بالتي هي أحسن فإذا الذي بينك وبينه عداوة كأنه ولي حميم وما يلقاها إلا الذين صبروا وما يلقاها إلا ذو حظ عظيم وإما ينزغنك من الشيطان نزغ فاستعذ بالله إنه هو السميع العليم صدق الله العظيم.
صدق الله العظيم. حيا هلا بكم وبجمعكم الكريم. تحيتنا من الأعماق فاح عبيرها العطر بأجنحة من الأشواق تأتيكم وتبتدر. لأنتم صبحنا الآتي به الظلماء تندحر. أيها الأخوة الأفاضل، لا يشك أحد ولا يتمارى أن مقام العلم وأهله مقام لا يجارى، وميدانهم ميدان سبق لا يبارى. فالعلم شرف الدهر ومجد العصر وتاج الشرف لكل قطر، وهو فخار الزمان وإكسير الأمن والأمان وضمان السعادة والإطمئنان. فكلنا فخر أن نكون بين علماء وباحثين نذروا أنفسهم خدمة للعلم والبحث وإسهاما في تخفيف آلام المرضى والمحتاجين. وإن من دواعي سروري أن أرحب بكم اليوم لليوم الثاني في مؤتمر المدينة النبوية السنوي للسكري لعام 2022، والذي نظمه نخبة من العلماء والأطباء والأكاديميين والممارسين الصحيين الذين واصلوا الليل والنهار لعقد هذا المؤتمر في خير الديار تحت مظلة مستشفى الأمير محمد بن عبد العزيز التابع للشؤون الصحية بوزارة الحرس الوطني، ممثلة في إدارة الدراسات العليا والشؤون الأكاديمية، وبالتعاون مع قسم الطب الباطني وطب السكري. وفي هذا المقام يسرنا ويسعدنا أن نزف لكم خبر اعتماد برنامج التخصص الدقيق زمالة طب السكري في مستشفى الأمير محمد بن عبد العزيز بالمدينة المنورة ابتداء من شهر يناير لعام 2023 كبرنامج معتمد من الهيئة السعودية للتخصصات الصحية، مما يساعد في تحسين جودة الخدمات الصحية المقدمة للمرضى في المدينة المنورة جنباً إلى جنب مع المراكز المعتمدة الأخرى في أنحاء مملكتنا الحبيبة، ومما يساهم في تخريج نخبة من الاستشاريين المتخصصين في هذا التخصص الدقيق والهام في هذا العصر، جعله الله باكورة نجاح وخير لتخصص طب السكري في المدينة المنورة. والآن أترككم مع كلمة سعادة رئيس اللجنة التنظيمية الدكتورة أريج بن مشعل الجميدي. فلتتفضل مشكور.
بسم الله الرحمن الرحيم، والصلاة والسلام على سيد الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه وسلم. وها قد وصلنا معكم اليوم للحفل الختامي لفعاليات مؤتمر المدينة المنورة للسكري في عامه الثاني. نفع الله بنا وبكم وجعله خالصا لوجهه الكريم. وبهذه المناسبة نتشرف بتقديم الشكر والعرفان لسعادة المدير التنفيذي لمستشفى الأمير محمد بن عبد العزيز بالحرس الوطني في المدينة المنورة الدكتور تركي الوسيدي على اهتمامه بالجانب العلمي والتعليمي ودعمه الدائم وتواجده معنا اليوم. كما نخص بشكرنا الشريك الاستراتيجي والمستضيف الرسمي للمؤتمر في الغرفة التجارية بالمدينة المنورة والأمين العام المهندس عبد الله أبو النصر. كما نتوجه بالشكر والعرفان لجميع المشاركين والمتعاونين معنا في الأركان المصاحبة لمعرض المؤتمر هذا، ولا ننسى أن نعبر عن سعادتنا بتواجدكم معنا خلال أيام المؤتمر العلمي، بما في ذلك ورش العمل والمعرض التوعوي المصاحب والبحوث العلمية المشاركة، سائلين الله عز وجل أن يعيننا وإياكم لما فيه خير الإسلام والمسلمين، وأن يجعلها صدقة علم جارية إلى يوم الدين. شكرا لكم.
ومع كلمة المدير الإقليمي للدراسات العليا والشؤون الأكاديمية الدكتور أنس بن مولوي خليل.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا ونبينا محمد وعلى آله وصحبه أجمعين. أما بعد، يطيب لإدارة الدراسات العليا والشؤون الأكاديمية بمستشفى الأمير محمد بن عبد العزيز الحرس الوطني بالمدينة المنورة أن تتقدم بخالص الشكر والتقدير لجميع من شارك وأسهم في إنجاح المؤتمر الثاني لمرضى السكري بالمدينة المنورة، ابتداء بسعادة الدكتور تركي الوسيدي المدير التنفيذي للخدمات الطبية في الحرس الوطني بالمدينة المنورة على جهده وتشجيعه الدائم للإدارة، مرورا بالشريك الاستراتيجي غرفة المدينة المنورة ممثلة بسعادة المهندس عبد الله أحمد أبو النصر. شكرا جزيلا لكم. كما أتقدم بجزيل الشكر والتقدير للجنة العلمية المنظمة للمؤتمر برئاسة الدكتورة أريج الجميدي والدكتور يوسف العلوي على حسن التنظيم والاختيار، وأشكر جميع المتحدثين والمشاركين من جميع أنحاء المدينة، جامعة طيبة ووزارة الصحة، فشكرا لكم لمشاركتكم الفاعلة. كما تقدم إدارة الدراسات العليا والشؤون الأكاديمية بالشكر والتقدير الجزيل لغرفة المدينة. أتقدم أيضا بخالص الشكر والتقدير لجميع الشركات الراعية والمنظمة للمؤتمر، والشكر الجزيل للمنظمين والمتطوعين من الجهات الأخرى، فشكرا جزيلا لكم وأسعدتمونا بوجودكم. السلام عليكم.
ومع كلمة راعي الحفل سعادة المدير التنفيذي للخدمات الطبية بالحرس الوطني بمنطقة المدينة المنورة الدكتور تركي بن عبد العزيز الوسيدي، فليتفضل مشكور.
السلام عليكم جميعا. رحب فيكم جميعا في المؤتمر الثاني السنوي للسكري في منطقة المدينة المنورة 2022. كما أود أن أشكر اللجنة المنظمة واللجنة العلمية القائمة على المؤتمر قيادة الدكتور أنس خليل والدكتورة أريج والدكتور يوسف العلوي كمنظمين للمؤتمر والمشاركين في اللجان العلمية واللجان التنظيمية. يسعدني كذلك أن أشكر سعادة الأمين العام المهندس عبد الله أحمد أبو النصر، الشريك الاستراتيجي من الغرفة التجارية، على دعمهم لهذا المؤتمر وإنجاحه. كما أشكر جميع الداعمين للمؤتمر والذين ساهموا بشكل يعني يشرف لإنجاح هذا المؤتمر بكامل صوره. ولا يفوتنا شكر المتحدثين الذين أبدعوا وشاركوا زكاة علمهم لهذا الجزء المهم جدا في تثقيف المجتمع وتثقيف الكوادر الصحية لتطوير برامج الحماية كبريفنشن للديابيتس وبرامج منع مضاعفات السكري في حال حدوثه. الشكر موصول للحضور، كما نشكر الأخوة المشاركين في المؤتمر من وزارة الصحة، ونشكر حضور الجميع من طب الأسرة في مستشفى الحرس الوطني ووزارة الصحة على مشاركتهم، كذلك الجامعة الطيبة ممثلة بالدكتور نويد الزمان والذي له إثراءات جميلة في هذا المؤتمر. شكرا لكم جميعا، ونتمنى دوام هذا المؤتمر بنجاحاته سنويا، ونرى فعاليات أكثر في المستقبل وبرامج وشراكات تنم عن نجاح هذا المؤتمر إن شاء الله في القريب العاجل. شكرا لكم جميعا.
الآن مع تكريم الجهات الراعية والجمعيات المشاركة في هذه الفعالية، جمعية المدينة المنورة الخيرية للسكري سكر، جمعية السكر السعودية الخيرية، مركز السكري مستشفى الملك فهد، مركز الأطراف الصناعية بمستشفى التأهيل الطبي، شركة نستله، شركة نوفو نودسك، شركة نوفارت، شركة صلات الأعمال التجارية، شركة أوجينال فيليفر. ومع متحدثين المؤتمر الدكتور سامية صبر. دكتور سهى عبد الجواد. دكتور سامي الرحيلي. دكتور محمد البلوي. دكتور بشرى الردادي. دكتور عبد الهادي حبيب. دكتور إيمان الفضلي. دكتور عمر عبد العال. الدكتور شعيب كوسجي. دكتور أبو عبيدة عبد الرحيم. دكتور نويد الزمان. الدكتورة سامية بخاري. الدكتور عبد الحليم المرعشي. والآن مع تكريم مستضيف الحفل بالغرفة التجارية. وفي الختام نشكر لكم حضوركم الكريم والصلاة والسلام على أشرف الأنبياء والمرسلين. يا اخوان ناخذ نصف ساعة استراحة وتبدأ بعدها ورش العمل بالدور الثاني ان شاء الله.